Hello, good morning, good afternoon, good evening, and welcome to the global webinar on public health. This is Nawaz Sheikh, your host for this conference, and let's begin the conference. Uh, I request Professor Rotislav Stefano, who is the chairman of this conference, to start this conference with his introduction speech.
Okay, thank you so much. Can you hear me, please?
Yes.
So, dear colleagues, good morning, good afternoon, good evening to all speakers, delegates, and students, participants all over the planet, and welcome to the global webinar on public health organized by the Global Scientific Guild. My name is Rostislav Kostadinov. I'm a professor in Medical University of Plovdiv, Bulgaria. I have the great honor and pleasure to be the chairperson of this conference. Most probably, the organizing committee has chosen me due to my third specialization into the field of disaster medicine. Every one of us is aware about the ongoing epidemiological situation that is evolving, unfortunately, every day. And once again, unfortunately, is rapidly approaching the edge, separating crisis from real disaster. Dear colleagues, please allow me on behalf of the organizing committee, with great pleasure, to welcome you to our meeting. Thank you all for attending the conference. Today marks an enormous event initiated by the Global Scientific Guild, which will provide all of us with the opportunity to share research findings and encourage new collaboration to interact in various areas of public health. The Global Webinar on Public Health is a scientific congregation that brings together researchers, scientists, key decision makers, industry professionals in the same physical space for a brief but yet intensive period of discussion, collaboration, and I hope generation of innovative solutions to address overarching challenges related to the theme, insights and innovation in public health progressing to the future. Throughout the webinar, 30 researchers will share with us the results of their research, observations, reviews on diverse aspects and challenges public health providers are facing nowadays. The main topic, obviously, is the ongoing COVID-19 pandemic. Several of the interventions are describing its different areas, from diagnostic approach and pure clinical insights to its impact on public health systems on national, regional, and global level. The presenters will discuss from how and what to communicate, what, when, and how to act during the pandemic, till planning and execution of post-COVID activities. Several significant for the public health topics regarding the epidemiology of infectious and non-infectious diseases with great social impact are also to be discussed. The third main topic of the conference is dedicated to the developing and implementing strategies for building up better and more resilient to the novel health threats, sustainable healthcare systems. The lecturers will address the ways for improving pre-hospital, hospital, and post-hospital patients management, along with healthy living promotion, from students, population health education, to the implementation of the novel information and communication technologies into the daily routine medical and social care providers practice. We are very pleased to welcome again you both to share the wit and share in witness advances in this field together. The conference has attracted speakers and delegates from all over the world. Therefore, I greet you with morning, good afternoon, and good evening, because we are all over the world. The Global Scientific Guild also wishes to thank all the organizing committee members who have put in long hours and efforts and have generated many creative ideas to bring this meeting together. Finally, we thank each and every one of you, the participants at this conference. We hope you enjoy the conference and that your participation will lead us to new ideas, collaborations, and research initiatives. So, welcome and let's start.
Thank you, Professor Rotislo, for the opening speech. And I request Professor Swapna Chaudhary to give her introduction speech.
Yes, Mr. Nawaz,
Yes.
the sound is very low. So a very good day to all the speakers, delegates, and student participants, and welcome to the global webinar on public health 2021. I'm Professor Swapna Chaudhary, working as an emeritus medical scientist at Chittaranjan National Cancer Institute, Kolkata. And formerly, I was the professor and head of laboratory medicine of School of Tropical Medicine in Kolkata, India. And today I'm the co-chairperson of this conference. And on behalf of the organizing committee, it gives me great pleasure to welcome you to our meeting, the global webinar on public health, organized by the Global Scientific Guild. The theme of the webinar is Insights and Innovations in Public Health, Progressing to the Future. Public health has been defined as the science and art of preventing disease, prolonging life, and improving the quality of life through organized efforts and informed choices of society, organizations, communities, and individuals. The public can be as small as a handful of people, or as large as a village or an entire city. And in the case, as in this pandemic, it may encompass several continents or the whole world. The concept of health takes into account physical, psychological, and social well-being. Public health is an interdisciplinary field encompassing epidemiology, biostatistics, social sciences, and management of health services. Other important subfields include environmental health, community health, behavioral health, health economics, public policy, mental health, health education, health politics, occupational safety, disability, gender issues in health, and sexual and reproductive health. Public health, together with primary care, secondary care, and tertiary care, is part of a country's overall healthcare system. Public health is implemented through the surveillance of cases and health indicators, and through the promotion of healthy behaviors. The purpose of a public health intervention is to prevent and mitigate diseases, injuries, and other health conditions. The overall goal is to improve the health of populations and increase life expectancy. With the onset of epidemiological transition, and as the prevalence of infectious diseases decreased through the 20th century, public health began to put more focus on chronic diseases such as cancer and heart disease. A major public health concern in developing countries is poor maternal and child health, heightened by malnutrition and poverty. Public health surveillance has led to the identification and prioritization of many public diseases, waterborne diseases, zoonotic diseases, and antibiotic resistance. The World Health Organization, or WHO, is a specialized agency of the United Nations responsible for international public health. The WHO Constitution, which establishes the agency's governing structure and principle, states its main objective as the attainment by all peoples of the highest possible level of health. Now, thank you all for attending the conference today to share and witness advances of this bill together. The conference has attracted speakers and delegates from all over the world. I'd like to thank all of the speakers and event partners for their continuous support and patronage. The Global Scientific Guild also wishes to thank all the organizing committee members who have put in long hours and generated many creative ideas to bring this meeting together. Finally, we thank each and every one of you the participants at this conference. We hope you enjoy the conference and that your participation will lead to new ideas, collaboration, and research initiatives. Thank you.
Thank you, Professor Swapna Chaudhary, for the introduction speech. Thank you so much. And the first speaker for today is our chairman of our conference, Professor Rostislav Stefanov. He's from Medical University of Plovdiv, Bulgaria, and he's going to give a presentation on COVID-19 medical communication lessons identified. And I request Professor Rostislav to start his presentation.
Thank you so much. Now I will share my screen. Could you see it now?
Yes, yes, yes.
Okay, just a moment. Now I will load my presentation and
Yes.
I will start. So, dear colleagues, as I said, I'm a professor in disaster medicine, and what I have learned throughout my long years of experience as a military medical officer, I understood that the most important in one decision making is to have a clear, updated, and undisputable, proved, secured, and reliable information. Therefore, I choose to speak today in front of you, of your distinguished audience, regarding what we have done wrong in this year and a half of COVID-19 pandemic. And what we have done wrong is because our medical communication was really close to zero. So, very short slide regarding the agenda. I will just say a few words regarding what is the area of biological damage and epidemic or pandemic. What are the medical support principles for eradication of this area of biological damage? In these principles, dear colleagues, are with thousands of years of history. These principles were established and set up after thousands of epidemics. And all of a sudden, we are violating, we're jeopardizing these principles, and we are observing the results of this. So, as I said, I will pay attention only to what data was and what data has to be communicated, what and how we have done, and what we're supposed to do. Of course, this is my personal opinion. So, when we're speaking about the area of biological damage, desperately we need a biological agents. They could be viruses, they could be bacteria, they could be parasites, fungi, or they could be only some toxins that are related to above mentioned. Then, in order to achieve the spread of these biological agents, we need that this agent should be contagious, virulent, and what is most important for us as a medical person is what is the way of transmission. Do we have transmission only from the source, or we could expect a human-to-human transmission? So what are our medical losses, our casualties? Are they only a primary when they are with vectors, or by drinking water that is polluted, or breathing a polluted air? Or we could have a transmission human to human. What is the lethality of these biological agents? Do they cause a fatal exit, or they only have a morbidity capacity, but they do not kill the casualty, the patient? And then related to all of those, what is what are the measures for consolidating, isolating, and terminating the spread of these biological agents, and of course, what is the treatment required for those that have been infected. But this is just a very brief remembering of these postulates in medicine. I will show you just a few examples. What was done in case of pandemics? The most important it was the isolation. In the isolation, several years and even decades in Europe, especially, when we have a black death, the plague. No one was allowed to exit from their homes. And as you could see from the more the times that are more modern, the military, the armed forces were entering in order to put the quarantine. What else was needed? As you could see here, I'm jumping from Europe to the Americas. When we have a quarantine hospital, this hospital is really isolated from the others, because there we are treating casualties that could infect the society. How many are the countries that have done this? Or in most of the countries, what we have done and what we are doing even today, we are opening what? COVID units in different hospitals. And I'm ashamed with the example that I will give you, but in our proper military medical academy, we inserted a COVID unit in the middle of the hospital, on the 5th and 9th floor. What is going on? What we have done with the historical evidence of the successful management of the epidemics? What is more, what was done some years ago when we had an Ebola outbreak in Africa? A real quarantine, cities, villages, hospitals, camps. But nowadays, what we are doing, I have no idea. But not everywhere. We have seen that some of the countries have imposed a real quarantine with armed forces. This is what is needed. When there is a risk, elevated risk, I will not speak about the threat, but when we have a high risk for human-to-human transmission of something that has a lethality capacity, we do require this type of isolation. No movement. What else do we require? We require search and rescue medical teams to go home to home to every single ordinary citizen to ask him regarding the status and to measure, to look after the symptoms. What else we need? We need a real effective decontamination. This is what history has taught us. And I would like to say that these lessons were learned with thousands and millions of lost human lives. And all of a sudden, there are very few countries that have made these simple steps, and we could see what are the results there. So I'm jumping directly to my topic. And dear colleagues, today my intention is not to share some observation, not to make a review of our errors, but we to start to think, to discuss, are we wrong where we are wrong. If we are wrong, I will expect your opinions. And if we conclude that there are some mistakes done, how we as a healthcare providers, as a managers, could give an advice or even lead a proper, adequate activities for eradication of the pandemic. So I have some slides. In these slides, I have highlighted the topics that are a must to be communicated with the medical community, with the law enforcement agencies, with the ordinary citizens. Because if they do not know the answer of these questions, they will not accept what we are proposing and what we are doing, and they will revolt. And as we can see nowadays in France, in Italy, in several other countries, we have a civil unrest. The population is disagreeing, is arguing, is protesting against the required medical measures. So the most important that has to be communicated is where is the threat for the health and life. And I'm speaking here not for the hazard. I do not want we to communicate with the ordinary citizens the chain of the virus, the different types of spike protein and other proteins that are what is the cell membrane or whatsoever, because they do not have sufficient background to understand what we are speaking about. But they should know that there is a real threat. And even if we impose all required measures, as I have presented into the previous slides, the disaster is on. The epidemic is here. It's killing our friends, our relatives. So therefore, it's not a risk, it is a threat. And we have to do something about this. How the agent is transmitted. Again, what the public, what the society is expecting from us, from medical communities, to know clearly and in comprehensive manner how it is spread and what we have to do. There is no need of a lot of information. It could be by the dirty hands, it could be with water. We were inhaling it, but if we are into 1.5 meters or 1.75 centimeters, the public is not interested on this. They would like to know how it is transmitted, what we have to do. And then in order we to gain and our allies in our fight against the epidemic, we need a citizen, an ordinary citizen, everyone in each village, notwithstanding how remote it is, to know what are the main symptoms and complaints that are suspicious, that most probably could be because of this biological agent. Why? Because if our population knows this, they will look after such symptoms in themselves, in their families, in their friends, and they could support us into finding out those that are already infected and what prevention is required. Here, the problem is huge. If we are explaining to the population that if you stay 1.5 meters from a person, you will be never infected. If this is already explained from the authorities, then how you explain to the population that an isolation and quarantine is required. They will say, I will not become close to the others, and I could go for shopping, I could go to the seaside, I could go even to a theater. Why there is a need of isolation? Why we need a lockdown? So we have to be very cautious how we're explaining what we are doing and what for we're doing this. Then the next thing is what and why have to be done on community and on the individual level. And it is related to the previous point. If we have explained, and if everyone has understood why and what kind of prevention is required, then it will be very easy they to accept the measures that have to be done from every single citizen, from every branch, from every company. They will know this and they will not complain. Of course, next thing that has to be communicated is the main public concerns. Nowadays, we're privileged with the social media because we have a real-time access to the concerns of the public. We could read what they're interested in, what are the main issues that they have a doubt on. And then in our communication, we will address this, but again in plain, comprehensive language. Otherwise, they will not understand what was said in previous slides. And then, what is the main public concern from this year and a half? The economics. Several times there were questions. We prefer to die probably from the virus instead dying from famine. So, how we could address this concern? We have clearly to state what every country, what the international community is doing for decreasing the economic burden, how they could survive the impact of these preventive measures on short and a long term, how they will survive, how they will feed their families. This is what is most important, because if we do not communicate this, we will never achieve the response from the public. Again, very important is how we are presenting our ideas. Because I will give example from our country. In the beginning, there were from a very high authorities statements and messages. Do not be afraid. This is only a normal common flu. Nothing unusual. Do not pay attention. Be happy. Afterwards, in 2 weeks' time, there will be a need of a trucks for collecting corpses. Sorry. Even I, as a medical professional, as a former military medical officer, as a professor in disaster medicine, I was really confused with what I was hearing from the policymakers, from the medical and political authorities. So the consistency, if we want the citizens to believe us, to follow us, to do what we require from them, we should be consistent in what we're saying. And of course, the personal example, how the leaders, public figures, the influencers in social media, what is their approach and behavior? Because when a professor or associated professor in front of TV or radio is broadcasting the ideas there is no need of masks or there is no need of vaccines because the vaccines are not so well done. If some influencers are sharing the results, what is going on, how many of those that have had already full vaccination, 2 shots, and again they admitted in the hospitals, what we could expect, how we could increase the desire, the willingness of the population to be vaccinated. I know that there are still a lot of questions to be cleaned up regarding the vaccines. But is this the right place to make this clarification in front of all the public, to confusing those? And nowadays, we are observing the result. We are harvesting these results. Why we are surprised that there are a large amount of population that is not willing, that is even against a vaccination, because a lot of confusing data was discussed in front of all the public, and this is the result. Just I'm giving you one result. You could see we are making an isolation at our homes. We could not exit from the town, but the planes are arriving from the other countries. Is this one ambiguity? Do we have an oxymoron here even? Those that are arriving from different countries are allowed to enter the country, but you are not allowed to exit from your town. What's going on? This is a normal question from a real, normal, ordinary citizen. So we have to think about how we are imposing the measures. Now, how the communication has affected the pandemic, because we have failed. This is my opinion, of course, it's personal opinion. We have failed to explain these citizens about the virus, how it could be imported from outside, from these planes. Because of this scarce border control, that is again because of the improper communication, we have what is the result? A lack of efficient isolation. Sorry, could you think about efficient, effective, adequate isolation on a seaside? Is it possible? I have great doubts about this. So, as we are communicating the population that during the summertime, the temperatures are killing the virus, and we are assuring those that if you are vaccinated with 2 shots, you are not a carrier, you are not transmitting the virus, and this is the result. And what we are observing nowadays, the following wave of infected patients, the number is increasing all over the world. When we have a not good communication with in our own community, this leads to the efficient epidemiological surveillance. About the search and rescue, how many other countries that are allocating resources, sanitary resources for search and rescue? How many of the voluntary organizations were educated, were taught how to protect themselves in order to support the healthcare systems that are overstretched with these demands? And again, because of not efficient, a real I will not say this word, I will say a real improper communication between us. What we have done? Do we have an isolation of those persons that were in contact with the symptomatic one? Have we controlled, have we monitored their isolation, or we just said, we propose you, or you have to stay at your home? But if someone is forced to stay, but there is no one who is looking after his or her isolation, we could not expect that they will obey, especially for a long time. So here we have seen the result of improper communication to the public and the results of improper communication to a medical community. I will give you an example. Again, please look at my face. I am blushing because this is our hospital in Bulgaria. Half of the floor is a COVID and the other half is not COVID. Great. Absolutely great. So therefore, again, have we communicated every single healthcare provider to know what to do into the pre-hospital environment? Have we dedicated quarantine hospitals? What passive immunization we have proposed to our policymakers? And I will not speak about the vaccination campaigns because they're real weak, and we could see the results. Now we have reached the point that we have to inform groups of professionals to be vaccinated. Why we are doing, why we have achieved this? Because our vaccination campaigns were in vain. I think that we could say nothing more that is presented on this slide. Could you see the personal approach of the prevention from an officer that is from the authority? If the authorities are behaving like this, what we could expect from the ordinary citizens? And I would like to say that a lot of medical professionals are behaving like this. So when we're speaking about the approach and behavior from the political leaders, please excuse me, I do not want to give an examples. We have seen them, let's say we are seeing them every night during the news. A lot of recognized medical specialists are taking their 5 minutes of glory in front of different medias and trying to explain things that they are not specialists, not at all. Cardiosurgeons, neurosurgeons, gastroenterologists or surgeons, abdominal surgeons are speaking regarding the vaccines, are speaking regarding the virus. What for? We have an epidemiologist, we have infectious diseases, we have public health specialists. They are supposed to give the speech. Not everyone with some degree of some position into a university or medical institution has to be allowed to speak of this, because we are giving very contradictory signals to the public. This is what I'm saying, medical community. And therefore, when the medical community, when the authorities are not behaving in a proper way, why we have to blame the social media? They are looking how to become more influencing. So most of the times they are starting to be against what is accepted, especially when they could rely on a statement of in brackets medical authority. So way ahead. I think that my time is already completing. So what is the way ahead? We have to start to think about a real crisis PR, public relation in crisis, because we are in a crisis, and this crisis could develop into a disaster. And we have to obey the norms, the rules of the crisis PR. Every statement has to be planned, has to be coordinated, has to be common, has to be comprehensive. And we have to repeat and repeat the statements in order they to reach the most remote parts of the minds of our compatriots. We have in our statements not only to speak what is going on, but we have to give an examples that will address the community concerns. Of course, we have to think about where is the best location for scientific discussion. From my opinion, from my point of view, scientific discussions on the research, on some industrial problems, on technological processes are to be kept into the scientific or producing communities. There is no need to confuse the citizens. And of course, at last, because now we are speaking for a pandemic, something that is affecting all over the world, we have to think about a common, unitary, international effort led by a worldwide recognized leading organization. Here, I'm opening a discussion. Who has to be this world recognized organization? Should we rely on World Health Organization in its expertise, or we should obey to a single nation to lead the fight against the pandemic? So with this, I would like to, I welcome your comments, your proposals, any questions. I think that we have 6 minutes left. So I'm open for discussion. Any discussion?
Thank you so much, Professor Rotislo. That was really an excellent presentation.
Okay, so
questions? Any questions?
I do not have any questions till now. I would like to share, because I will share my presentation. The last slide is with my email. So I thank you for your attention, and I'm really waiting your questions on my email. Once again, wishing you a plausible and fruitful conference. Thank you.
Thank you so much, Professor Rotislo. Our next speaker is Dr. Elida Mataj. She is Chief of Environmental Epidemiology, Institute of Public Health, Albania. And she is going to give a presentation on distance learning, epidemic and pandemic outbreaks in Western Balkans, Albania. And I request Dr. Elida to start her presentation.
Yes, I am here.
Yes.
At the first, I want to thank you very much. Sorry. That you invite me in this activity, more important in this situation, pandemic situation. My presentation is not in general about the situation of pandemic in Albania, but I am focused in one study that we have done during 2020. It is called distance learning on epidemic. Yeah. And especially in this project, we have done an evaluation of microbiological laboratory capacities in Albania, especially for Albania, but I don't know the other Balkan countries if he's done about their laboratory or any topics defined in these projects. I want to share now and to explain what we have done in this project. Yeah. I don't know if you can see.
Yes, we can see. Please continue.
Please, you can see my presentation.
Yes, we can see your presentation.
Yeah.
Please continue.
Okay. As I said before, in the study has been included some Balkan countries. Has been necessary to do this project, especially in the conditions of epidemic and pandemic situations, because in the Balkan countries, the capacity to implement effective actions during emergencies seems to be very limited. From the health perspectives, given the explanation of the definition of public health and well-being to include social challenges, economic values, security, etc., we realized that technical skills and in general the capacity of social, economic and environmental systems, along with the experts and at the central and local level. At the first slide, I want to explain how in Albania is organized the health system. The health system in Albania is mostly public. The state provides most of the services for the population in the field of promotion, prevention, diagnosis, and the treatment. The private sector is still in its infancy and covers most of the pharmaceutical services, dental services, and some specialty diagnostic clinics, which are mainly concentrated in Tirana, capital of Albania. In the public sector, the role of leader is played by the Minister of Health and Social Protection, which is the drafter and responsible for the policies and strategies of the health system, for its regulation and for the coordination of all actors inside and outside health system. The diagnostic and curative health services is organized in 3 levels: primary services, secondary hospital services, and tertiary hospital. Public health and promotion services are provided in the framework of primary health and are supported and supervised by Institute of Public Health. Regarding the laboratory, that the scope of our study has been evaluation of microbiological laboratory capacities. In the Albania, the services of medical laboratories, especially clinical biochemistry and microbiology, is as below: medical laboratories in public hospital service and medical laboratories in the public primary services. Organization of medical laboratories in the hospital service are in medical laboratories at the district hospital, medical laboratories in the regional hospitals, and medical laboratories in tertiary hospitals, especially university hospital, which are also a reference laboratory. In Tirana, such as capital of Albania, we have medical laboratories near the specialty called polyclinic, and medical laboratories near the health centers. In the district, these laboratories are nominated as a medical laboratories near health centers, laboratories at the regional directorate of health, and laboratories at the district public health directorate. The aim of this study that we have done has been to strengthen the abilities of all parties to effectively, timely cope with outbreaks, preparedness and response, promoting and cross-border cooperation, and to identify the capacity of each about the public health surveillance system, as well as regional communication channels to be activated in time of epidemic and pandemic situations. The objective of this study, the overall goal of the project, it has been to improve outbreaks reduction skills and the resilience building practices through a region-wide harmonized system of learning. The specific objective has been to establish a plan for action to address regional challenges to be translated into smart training opportunities to enhance at the regional level the public health technical capacity of selected experts to provide technical assistance for building community resilience practices and skills. Also to do a mapping of national surveillance system and diagnostic laboratory to develop permanent open source for sectoral how exchange on the topic. At the end of this specific objective has been to ensure adequate availability of quality public health training programs in higher educational institutions in the Balkan region. The methodology that we have done for explain to complete the questionnaires that has been for this study, based on the aim of the study, we have selected 6 cities for completing the questionnaires. I can share you and the questionnaires that we have used for collection of the data and to do statistical elaboration to present the results. As I said, in the 6 districts we conduct the study. in the 6 districts, we have been 14 public microbiology laboratories. The questionnaires were completed by responsible persons of these laboratories, supervised by the specialists of the projects. The purpose of this survey was to evaluate the functioning of these laboratories in terms of quality of services and infrastructure. 3 has been questionnaires or divided in 3 parts. The first part of questionnaires has been mapping the equipment on the public microbiology laboratories in Albania. Second questionnaires has been regarding the need of the with the equipment for these laboratories. And third questionnaire has been improving microbiology diagnostic system quality in the function of surveillance system. The study, as I said, included 6 laboratories in 6 regions, and in total 14 microbiological laboratories, concentrated in the hospitals, districts, and primary health care units. Regarding the results that we derived from the statistical elaborating, we can say that for first questionnaire, which has been mapping the equipment in public microbiology laboratories in Albania, I can say that in the total that listed 45 equipments in Albania. In these laboratories, we have lack about 17 equipment or 37.8% of equipment missing in these laboratories. I put all the equipment, 38 equipment described in the questionnaire. The district that are in the study has been Tirana, Durrës, Gjirokastra, Pogradec, Kukës, and Berat. As you've seen in yellow, I mentioned that the city and the equipment that missing in the spread in the distribute in the cities in Albania. I don't know if it's clear from you this table for you. Sorry, is clear?
Yes. Please continue.
Can I continue?
Yes. Please continue.
Yeah, thank you.
Continue. Yeah.
I don't know what is happened. Yes, thank you. About the results of questionnaire, second questionnaire, I can say that the results obtained in relation to the needs of laboratory equipment defined in the first questionnaires, as the need for each device is able to work all investigated laboratory have studied that they are mainly necessary for diagnosis, for surveillance, and for sorry, but I don't know what's happened.
Oh, no, we can hear you.
No, I can see anything. I don't
Can't see.
know.
Maybe there's a problem from your side.
The results from second questionnaire obtained in the relation to the needs of laboratory equipment defined in the first questionnaire, the reason for the need for each device is expressed from all of the experts from all the laboratories that we involved in this study. Regarding the, you hear me?
Yes, please continue.
Yeah. Regarding the third questionnaire, which has been related to improving microbiology diagnostic system quality in the function of the surveillance system in all the requirements that the questionnaire are include, are persistent in each of them. The tables that I have put everything, and now I will send to you and to see, especially an evaluation that we have mentioned in this study has been what this type of laboratory can do for diagnosis about if the laboratory can confirm meningococcus or bacterial zoonosis, fever Q, or streptococcus, and the results are very, very, very poor because more of them, more of laboratories, microbiological laboratories in Albania has not done the confirmation about more of the microbiological tests. In the conclusion, with all the results that we are obtained by from the statistical elaboration, according all the elements from three of questionnaires, we have mentioned lack of equipment in all laboratories, lack of equipment in some laboratories, and we divide in 6 laboratories. There is lack of distilled water. In 7 laboratories, there is lack of clean autoclave. In 13 laboratories, there is a lack of dirty autoclave and bioseptic class 1. ELISA equipment in 15 laboratories, there is lack bioseptic class 2nd, and so on, and the others equipments. The equipment available in most laboratories are not in good conditions. Because the time of using this equipment are from years 1990 19 to 2005. Specialists are trained in the equipment that is currently available in laboratories. Most laboratories use these devices only for diagnosis, but cannot use this equipment for the surveillance system of infection disease. All laboratories need the equipment presented for in the questionnaire related to the second questionnaire. Laboratories at the local level need these devices not only in diagnosis, but also in case of surveillance and outbreaks. Need for training of specialists in laboratories. Almost all pathogens are not analyzed. There are shortcases in the staff of microbiologists and permanent technicians in laboratories, lack of temporary microbiologists and technicians, lack of permanent molecular biologists. Some laboratories lack permanent healthcare workers and temporary ones, lack of staff supporting the laboratory in some laboratories, lack of national laboratory or partially available networks, lack of national sentinel network for virology laboratories, and lack of diagnostic capacity for coronavirus, avian influenza, Ebola virus, etc., that coronavirus now was done and in Institute of Public Health. Coordination is realized only for 1 to 5 infection disease. You hear me?
Yes, yes, please continue. Yes, I can hear.
There is no degree on the coordination of health laboratories and the definition of terms of reference, etc. We have recommended the development laboratory capacity infrastructure at level and at central and local level, assessment of capacity and geographic location of all available laboratories that would be able and considered to be capable of conducting testing of samples in Albania. Identifying the problems and bootlegs through method, validation, estimation of uncertainty of measurements, increasing and strengthening the capacity of microbiologists, molecular biologists, and laboratory technicians at central and local level. Regarding these conclusions and recommendation that we have present, considering the level of the all and the strategic documents for the surveillance of infection disease in Albania, especially surveillance of epidemic and pandemic situation, the Ministry of Health and Social Protection and Institute of Public Health has been supported by EU Commission to implement a twinning project, which is closing procedures and will start implementation at the end of this year. We hope that with this project, we can do something about to start with the strategic documents or most of documents that need for protocols and more of them that need to start. I put in the final slide about this twinning, because I am director of this project, and in aim of this project is to strengthen the epidemiological surveillance system of communicable disease in Albania, based on in line with EU European Union standards and international health regulation, specific objectives to improve the prevention and monitoring, reporting, management system and capacities on communicable disease in public and private laboratories, clinics and hospitals in Albania, in line with of EU standards. The component that we have mentioned in this project are three components. Regarding the component one is reviewing against EU benchmarks of the current legal, regulatory and institutional framework on the prevention and control of communicable disease. The second component, capacity assessment related to the infection disease surveillance system and for its improvement through digitalization of information networks. And the third component is capacity building in the preparation of specific programs and protocols related to preparedness and response to epidemic and pandemic situation on other communicable disease. I don't know what I can say. I want to thank you very much. And this in the difficult situation for my presentation. I don't know. I am at home and my internet is very good.
No problem. Thank you. Thank you so much, Dr. Elida. Thank you for the excellent presentation. Are there any questions for Dr. Elida?
Statement of the 4th of August condemning the attack against the UN office in Iraq.
Any questions?
We appreciate for the show of support for UNAMA, but more importantly, for the colleagues.
Thank you so much, Dr. Elida.
Thank you.
This solidarity matters to Afghans.
Our next speaker is Gabriela Penn-Nasser from the University of Freiburg, Germany. And she is going to give a presentation on the role of development organizations in fighting hunger and malnutrition during the COVID-19 pandemic. And I request Gabriela to start her presentation.
Thank you so much. I think there's a microphone.
Yeah.
Oh, thank you. Okay. Hello. Can you hear me well?
Yes, please.
Okay, I'll start sharing my screen. So, good morning, good afternoon, good evening. It's a pleasure to be here at the Global Scientific Guild webinar on public health. I will talk today about the topic, as mentioned, the role of development organizations in fighting hunger and malnutrition during the COVID-19 pandemic. First, briefly about me, I am institutional director of a nonprofit organization in Brazil called Instituto Melhores Dias. We develop programs for children, mainly in health prevention and community development. I live in Germany now. I completed a master's in global urban health, and I pursue a PhD in this area of public health and nutrition also here at the University of Freiburg in Germany. So I bring a little of both aspects of public health, which is research and also the civil society organization engagement. So why this topic? Yeah, why am I talking about this today? As we know now, after this 1.5 years of COVID, how many societies around the world were fragile in face of the health crisis. Countries such as Brazil, which came across huge number of COVID cases, were affected way beyond the disease. And there were silent workers bringing help for those that weren't able to reach out in these moments. And I'm going to share some examples of social and development organizations in Brazil, as this is my country, but I am sure that around the world, and you all that are present here from different countries are able to also think of, stories and social initiatives that have had an impact on populations. So the idea today briefly is to cover how Brazil was actually immersed in a crisis scenario before the pandemic, and then the situation of food insecurity, hunger, and malnutrition in the country. And lastly, what were some examples and the role played by these organizations in fighting these problems. So Brazil has, to give you a context of what I'm talking about, Brazil, as you know, is the largest country in South America. It has lived in the 90s and early 2000s, several reforms and improvements, both in economy, health, and social areas. In terms of labor, historically, Brazil has demonstrated high rates of informal labor and self-employment, as well as unemployment rates. However, in the early 2000s, we really saw the unemployment rate fall steadily, with the minimum wage also adjusted, and this led to a decline in poverty and income inequality within the country. In the social area, definitely the early 2000s were characterized by a strengthening of social assistance programs, which actually have been predicted to decline inequality by more than 20%. The Bolsa Familia program, it's a cash transfer program focused on families with children under 17, and it has some conditionalities, one of which is actually the monitoring of children and families' nutritional status, help to also reduce inequalities. And finally, in terms of health, the establishment of the national health system, which provides free access to health to all the population. It's called the Serviço Único de Saúde. And state and municipal levels also were responsible here with the decentralization of the administrative capacities. But what happened in the last years in Brazil, mainly after 2010-14, with a mounting of political and economic issues faced by the country, we had an impeachment, economic downfall, followed by more recently by an extremely polarized election in 2018. And it showed a scenario of a country that was actually very fragile and at the brink of a social disaster. So before the COVID-19 arrived in Brazil last year, we actually had a situation that 40% of the Brazilian working force was informal, 16.2 million were unemployed, showing a rising tendency. The unified health system suffered with lack of resources, lack of professionals, and other issues. And also there was again a rise in inequality and poverty due to a weakening of that social assistance agenda that was strong few years prior. In the area of food and nutritional security, which is the focus of this talk today, many advancements were made, especially with the Fome Zero program launched under President Lula's administration. Brazil was finally removed from the World Hunger Map in 2014. There was significant decrease in the undernutrition rate, mainly among children, and institutions such as the National Council for Food and Security were established, including the participation of civil society organizations in this process. So we really saw in this area more engagement of different stakeholders with more voice, ensuring that the population had access to more healthy and adequate food. But looking at, food and security, food and nutritional security in the last years, we notice again the country in a fragile state. By 2019, 85 million Brazilian homes had some degree of food insecurity, of which 10 million suffered of severe food insecurity. In terms of malnutrition data, the country faced what we call double burden of malnutrition, with high levels of overweight and obesity aligned with iron deficiency anemia, for example. In assessments done by our institute, an average of 27% of children are overweight and obese, were prior to the pandemic. And levels of anemia were as high as 55% in some municipalities. And so the current government that took office in 2019 already saw food and nutritional security agenda very compromised and complicated, but decided to extinguish it completely as the action of abolishing the National Council for Food and Nutritional Security, which included the participation, as I said, of organizations and communities. So with the pandemic, we have had almost 40 million students affected with no access to fresh foods, with the closure of the schools and the school meals. And we have a predicted 19 million people going hungry in Brazil as a result of the COVID-19 pandemic actions in terms of lockdown and other effects. This figure here shows the growing trend in food insecurity in the countries the last years, as I've been mentioning. You see here, mainly after this period of 2010-14 here, there's a significant drop in food security, and then continuous rise in the levels of food insecurity among families, households. This year, our institute also conducted an assessment with families using the Brazilian scale of food security, which is includes 14 questions adapted from the international scale used by FAO, by Brazilian researchers. We had a total of 2,389 participants, both online and in-person interviews. And currently, we found an even higher trend from the graph that I showed before. Currently, more than 65% of the families are suffering some level of food insecurity, meaning they're concerned with not having access to enough or quality food. 9% of the families are suffering from severe food insecurity, meaning these households are facing hunger directly, including children, which are more vulnerable and prone to malnutrition. Also, you see here, 37% of the households had someone who lost their jobs directly due to the COVID-19 pandemic, and 32% income reduction. And also 26% of them mentioned they suffered from a non-communicable disease, a chronic condition, which aggravates also health impacts caused by lack of nutritious foods and access to food. So now moving a little towards the topic of the developing organizations in Brazil and what are they doing. Yeah? A federal research institution has mapped out over 815,000 organizations currently in the country. Of course, they vary tremendously in size and scope of action, as you probably know. This map here shows the distribution of these organizations in the country. Some affiliated to religious institutions, other completely independent, other more community-based, and mainly they're more, if you see there, a lot of them are concentrated in the Southeast. Of course, this is the richest area of the country with more funding as well. And mainly these organizations have a role to play in terms of filling in for what the government has failed to or is unable to provide, for communities and populations in general. And also in many of these areas, they can't reach, everyone. So the organizations really play that role. And I want to point out also that I chose this topic today because I think it's important to bring to the attention that there are small-scale organizations and also big ones really playing a part in the fight for COVID, not only in health aspects, but also other aspects. And right now, of course, data is hard to come by in terms of this topic. The action of institutions is not officially mapped many of the times. Organizations don't have, such as academic institutions, the resources to develop adequate and full evaluation of their work, even though they have a lot of data. And I think now, probably in the near future, we'll have more numbers and stories that describe the impact that organizations have had in this area. But as a director also of an NGO, aside from being an academic, I believe it's important to call to the attention the impact that they can have on health and well-being of the populations. So Brazil has around 12 million people living in favelas. These communities, as you know, are mainly located in central urban areas with low infrastructure, as in many other countries, houses are very close to each other with poor ventilation and accessibility. The favelas don't have health institutions. The population have to travel, take public transportation for quite some time to reach a health center. This community we're seeing here is called Paraisópolis. It's located in São Paulo, the largest city in Brazil. And right from this photo, you can see the inequalities that are present here. Behind here is one of the richest neighborhoods in São Paulo. And in front, you have this massive area of houses. And it's around 100,000 people living in Paraisópolis. And when COVID-19 hit the country in the city of São Paulo, first thing was this neighborhood is prone for disaster, with numbers spiking, and because these people can't work from home, they're more exposed, more fragile, with much less access to service and no presence really of the state. So what happened there was actually an example of civil engagement. They have local committees and that are able to organize themselves with several actions. They elected one president per street, they would say, who are responsible for checking out the neighbors' health conditions weekly, almost daily, I think, if I'm not mistaken, and reporting. They controlling also the number of cases. They hired private ambulances and doctors that could help those that showed symptoms. This actually, I'm talking about early mid 2020. Okay, I think in the beginning of 2021, we had a more serious situation in Brazil, as you know, we had the second or third wave, and this didn't really work out so well anyways, but in the beginning, it was a very clear example of civil engagement. In terms of nutrition, they donated meals and also food baskets for those that required more assistance. These are some photos of the area, of the doctors visiting the streets of Paraisópolis, and this is the type of meal that they deliver to more vulnerable populations within the community. And also, if we look at what other organizations are doing across the country and have done in terms of collecting food for families, they have made coalitions, big organizations that have received donations from private companies, and this has certainly alleviated the current urgency of fighting hunger, food insecurity. The government also, these are, of course, the numbers are higher. This was what I was able to come up with in terms of research, but at least 15 million donated by private initiatives for this specific cause. At least 600,000 tons of food donated. And also the government provided, because Brazil has a federal meal program where kids eat in schools every day. And some municipalities, of course, more organized than others, were able to, with the money that came from the... Yeah? Is everything okay? Can you hear me?
Yes, please.
Okay. So with the money that came from the federal government for this meal program, some municipalities were able to provide... Yeah? Okay. Monthly cards for families, but also, of course, this is not equal in every town, and it's a short-term solution. And another approach for hunger alleviation and fighting food insecurity is the implementation, of course, of community gardens, which not only provides fresh foods, but also engages the population in learning about healthier food choices in a time like this. This is also an example of community engagement, which the idea of community garden came from this neighborhood, as you can see here on the top right. It's in the outskirts also of a large city, and they are located in a more vulnerable area. 80% of them lost their jobs. They had no resources to get food. And they had this area behind a school that they really wanted to do a garden. And sometimes they don't really find, they can't figure out for themselves how to do it. And that's one of the roles of NGOs and civil society organizations, to just give them tools at least to start. And once you give an opportunity, definitely the community engages itself and is able to change their environment. This community garden currently gives food to 200 people at least. So, the numbers we've talked about demonstrate the urgency to implement long-term behavior change interventions for the population, since they are at risk of developing further complications, worsened by inadequate eating habits. Certainly the malnutrition rates among children has grown. And the government cannot reach this multi-level approach by itself. So civil society organizations do have an important role to play not only providing assistance at times like these, but delivering information to communities at a local grassroots level and advocating for policy change in a more macro level. As I said before, the food baskets distribution to families, of course, it's important, but it's a short-term solution in a time like this. There needs to be a compromise from national and local governments also towards the food and nutrition agenda, which is essential in the next years and months. There needs to be policies aimed at generating employment, income also. And there needs to be more investment in small-scale farmers and family agriculture. And I just want to conclude briefly by saying that overweight and obesity and all the other malnutrition, levels that definitely have got worsened with this condition, not only Brazil but across the world. They have a multi-level dimension, and it's necessary now to develop alternatives that engage different actors. So it's important not to have just research in one area, specifically looking at one thing, but also but really engaging different stakeholders and involving the communities to look at what they're facing. I think it's important to create a network between schools, health units, also local leaders, families, and the researchers, to find alternatives for what will come up. It's been published in Brazil that local governments are not prepared for, don't have plans for the next months on how to address the impact that COVID-19 has had. So the coming months and years are crucial for governments, institutions, and civil society organizations also to observe and intervene in order to avoid worsened rates of childhood nutrition, obesity, undernutrition, which will bring definitely a higher rate of non-communicable diseases in the future. So thank you very much for your attention, and I'm open for questions.
Thank you, Gabriela. That was really an excellent presentation.
Nice talk.
Thank you.
Can you hear me?
Yes.
Yeah. I'm from India. I'm now talking from UK. My question is, as a underdeveloped or developing country, in your opinion, what all initiatives you found most effective in addressing the financial crisis in local population? I mean that some of you mentioned like the food baskets, monthly cards to the families. Which one you feel most effective to address the financial crisis? Thank you.
Thank you for your question. Actually, to address the financial crisis, it's complicated. It requires more time, and definitely now, looking at Brazil and historically, as I mentioned, we've had a lot of investment in the early 2000s when Brazil faced a lot of hunger and malnutrition and families living in poverty, which has been drastically worsened now. But there was a policy nationally towards generating employment and income, which is actually what is going to be needed, because as I said, the delivery of food baskets and food is an urgent matter that needs to be addressed. People are hungry. They have lost their jobs. Half of the population have lost their jobs or had the income reduced, so they can't afford food. So of course the private sector and is really donating a lot, individuals sometimes, but this is not going to alleviate unemployment rates or financial problems that the families are facing. Once these 1 or 2 months of food baskets are over, the families won't have any meals. Once the school opens, at least the children will have a meal a day, but that's not enough. So definitely there would need to be policies, national policies for generating income and employment to the population. And that's where I think maybe civil societies organizations can act in terms of advocating for this type of change. But it's a bit hard, and we know from our countries.
Sorry to intervene. I understand it's too many things are connected with this. Can you give a small example? As I'm just recently graduated, so how can we in ground level, in practical level, how can we execute a policy to generate employment or income?
I think there are definitely different types of programs around. There are, as I mentioned, the example of cash transfer programs, if it's possible nationally to do that, to give an allowance a month that really takes people out of poverty. But there are also examples, I think in India, there's a lot of examples of microcredit and this sort of thing. But I think it's a real blank now after COVID, because so many levels have been affected that I think new solutions would, I don't know, I think new solutions will need to be, we'll need to come up with different and creative new solutions, because not only communities were affected, but government, health institutions, everything. So, but there are creative programs in different countries that have, but it's all very local. I think nationally, what you have is these cash transfer programs that are very, in all of Latin America. Mexico also invested a lot in them.
Thank you so much. Bye.
Nozifo, please ask your question.
All right. Hi, everyone. Hi, Gabriela. So I just like to know if you know, you mentioned that they had appointed sort of a leader in every street to go and check fellow neighbors at the beginning of the outbreak. So if you do know, so you also said it didn't work out in the long run. Do you know maybe if they maybe instituted a different intervention? How did that end up? Thank you.
Okay, thank you for your questions. What happened is this, it really worked in the beginning. They were able to keep the numbers down incredibly. I can go look after that and send you if you're interested, because it's really interesting how they were able to control the outbreak in this specific community. But what happens is the people have to go out and work. They weren't able any longer to sustain staying there and living just with donation of foods. And as I said, this is a short-term solution that they found to. And most of these people that live in this favela specifically work around the city everywhere, in informal labor, or in in the, as you saw in the photo, in the neighborhood behind, in houses, and every sort of job. So they couldn't stay home. And of course, as you know, Brazil has had outbreaks for a full year. It didn't stop in terms of COVID waves. And the numbers went up. That's what I would say. I think it's not sustainable, to have an intervention, although it works. And for an outbreak, it really did work. And it showed a real good engagement of every level within the community. They had a committee and designated these people to take care of each area. But it's a short term if you don't have around also an involvement, and also if there were support from, you know, the employers, but there wasn't. So yeah, in the long term, it ended up not working. I hope I answered.
Any more questions? Okay. Our next speaker is Dr. Marian Gibber. She is Assistant Director of Public Health, Birmingham City Council, England. And she is going to give a presentation on using co-production and collaboration in recovery and planning public health services post-COVID-19. And I request Dr. Marian to start her presentation.
Is that okay? Can everyone see and hear?
Yes. Please continue.
Thank you. It's because in Birmingham, we will be having the Commonwealth Games next year. And so one of the things we're looking at is what is going to happen post-COVID at the moment. And so we're thinking how we can get the collaboration necessary to consider how we can recover from the pandemic. And Birmingham being a city with a huge amount of diversity, there is a lot of things to consider. So what I'll be talking about today is giving you a bit of an oversight of what Birmingham is like. Talking a bit about co-production, how we've worked with community leaders through the pandemic and are wanting to continue that work post-pandemic. Then we've been doing some work around digital public health through the pandemic, because lots of health issues have arisen, one of which was people wanting to stop smoking but not being able to access services because many of the services that were being provided was stood down because of the COVID response that was so essential. We also saw the mental health amongst young people deteriorate over the course of the pandemic. And we also saw people having more and more weight issues as we went through the through the lockdown cycles that we had. So what we're wanting to do is to try and make sure that the services that we're providing are really tailored to our communities. We want to use co-production and community research to do that. So here, what I mean about Birmingham is very diverse. It's also, we've got about 1.2 million people. We have some severe problems with infant mortality. It's the third highest rate of infant mortality across the UK. We also have lots of people who are in the most deprived areas, and they've got many problems, and they also die prematurely. We've got a lot more problems in certain communities. There's 19.6% of inpatients with a serious mental illness who are from Black communities. And it's pretty high amongst our Caribbean community as well. We can see that there's a huge discrepancy in life expectancy between our most affluent and most deprived. And you can begin to see that all of these problems mean that we have people who are impoverished have much more contact with our mental health services and more likely to have long-term conditions. And many people, in fact, have severe multiple disadvantages. And so these are the kind of, this is the background to our city. It's a city with lots of health inequalities, and we've painfully seen the increase of these inequalities throughout the pandemic, with the pandemic actually impacting far more on people from our minority communities than it has amongst the white population. And I think that's one of the reasons we then want to make sure that not just one particular community has a space for these discussions. We want to make sure that we're considering some of the power dynamics within our society. And many people who are impoverished aren't normally involved in decision making about what the services need to look like. They're not involved in the management of services, but they might be trying to access for services and finding it incredibly difficult to do so, especially if they have been impacted by losing their jobs, or many of them are in frontline work positions where they haven't been able to stop having to go into work. So many of the things that Gabriella mentioned from her presentation are similar in Birmingham as well. So I really think it's really important that we are asking communities about it and getting their input in terms of it's not just about what they think, but how they can work with us to make decisions and be part of the implementation, be part of how we evaluate and improve services together, so that we go through this whole cycle of co-design in a way where we're engaging our communities, we're planning with them, looking at all the different elements that are part of the issues, and developing solutions together, and then deciding which solutions are going to be the most appropriate and how that might lead to change. And that then we also need to bring in the whole evaluate and assess as part of this cycle, and make sure that we modify before we go on to the next cycle. So what we've been doing through the pandemic has been making sure we have regular meetings with community leaders. And we've done that through different ways. We've had interfaith meetings with representatives and leaders from our faith groups, which they've then met with us. Public health has been able to share information. We've had discussions, some of the topics around vaccine hesitancy and all sorts of different issues that we've really discussed, how to ensure that they can open up their worship places safely, so that we work together on guidance in terms of how to establish safe spaces and social distancing. Loads of discussions around singing, and it's very important that we are able to sing, and then how do we counteract the issues that arise from singing. Many of those issues, it's been very interesting indeed. We've talked about why it's important to get tested, how we increase the vaccine uptake. And then we've, over the course of this pandemic, we've enrolled, it's now nearly 1,000 community champions, and all of our faith leaders are part of that network, and so are our politicians as well, all of members. We've made the use of working with our voluntary groups or the community sector as well, so that they have been working with us to provide information, supporting people. Some of the things around, and not food parcels so much later on, but food parcels in the beginning, when we identified where our most vulnerable community members were, and voluntary organisations would take food parcels to them. And then in the next phase, we looked at how the food banks could help, and we had hubs across the city to ensure that people could be supported through this very challenging time. And one of the things that we've been doing of late is we're in the process of training community researchers so that we can do far more to really have these dialogues, which are so important if we're going to come through and be able to build on some of the positive things that have happened as a result of this pandemic, and ensure that people are able to get involved in some of the next pieces of work that we're going to be doing. So I know it's quite interesting, whereas you can't imagine talking about digital public health in developing countries, but we at least have that possibility in the UK. And I know that other places like India, we've been talking to around some of the digital work that they're doing. So what the pandemic has actually enabled us to do is to look at how we offer services in terms of different platforms, and to ensure that people can get access to services. And there's a national digitalization strategy that's been launched by the government as well. And we've been kind of making sure that we are fulfilling the requirements of that. And many of the offers that have happened to date have been much more health orientated. It's been through the National Health Services and the clinical care, being able to have your online consultations with your practitioner, rather than being around how we can ensure that people can maintain their health, can consider how they can look at their immunization status, what some of those things that they can help them not to get so sick. So we wanted to focus on that prevention of services and the way they might be delivered. And so one of the things that happened, all our general practitioners, they stopped all their preventative interventions. So all things like stop smoking that the GPs provide, and other elements that they offer, and also pharmacies. Because of the scale of the number of people who are impacted, they really did have to ensure that they use their time to support their patients. And so they kind of, prevention wasn't key to them. They were doing a curative service, and that was really what was needed. So we started doing a bit of research around what was available and what we might be able to offer online. And most of the digital offers that we found were kind of standard packages, and they weren't really tailored to our particular population. Some of them started moving online, but it didn't address the diversity, the language issues that we face in Birmingham as well. So we did a rapid review of services to look at how we could support smoking cessation. And we felt that this was really important, given that COVID is a respiratory disease, and that stopping smoking would help people to have a bit more of a being less impacted by COVID itself. And then since then we've looked at weight management services and supporting older people and children and young people around their mental health as well. So one of these was what was called Quit with Bella, which was a smoking app that we invested in. And this enabled us to continue to offer this smoking cessation. And it was really great that the organisation that provided this were really keen to work closely with us to see what Birmingham needed. And we used an emergency commissioning process for this, so that in order to enable that to take place. And what we were able to do is deliver a standalone service that included the provision of NRT and e-cigarettes as well. And there was a drop-in face-to-face online approach as well, that enabled us to provide over 1,000 individuals support to quit smoking over the course of the pandemic, which is pretty amazing. And what we ended up having is a situation where we ended up having greater quits than we did pre-pandemic. And we also helped, that Quit with Bella was able to assist a load of people to quit without the use of NRT as well. So we, as a result of the evaluation work that we did over that programme, we've now extended the contract, and we're looking to think about how we can change that in line with what's happening as we come out of the pandemic as well. One of the apps that we're using for mental health amongst young people has been one that's been worked on by the academic sector within Birmingham, and it's really great that they've been able to support young people in making sure that they can get support online through the pandemic, which has been very helpful. What we're doing with the weight management at the moment, Public Health England and the Department of Education, and we're now mapping services to look at the gaps and understand what the NHS is offering as well. And so we're going to commission services around looking at people who want to get involved with sport, people who've got visual impairments, physical impairments, how we can support older people, and this work around co-production is going to be really important as we undertake this. And what we are going to be doing is running a 12-week program, and we've established a set of criteria that's based on body mass index. We're adding another app, which is called Shape Up for Life. And so anyone who qualifies will be able to access the service digitally, and they won't be needing a formal referral from a registered health professional. And the app is great in that it really suits Birmingham, because there are different languages being offered. They look at the different foods that our communities use, the consideration of culture, and how we integrate it with our local offer that's both not digital and non-digital as well. So I just wanted to share one area where this co-production that I mentioned, that we've been doing a bit longer, and so we have a bit more of insight into this. So it's through looking at young people's perspectives, and also looking at how we can reduce our infant mortality rates too. So we've used a knowledge to action framework that's been very useful in terms of how we move from evidence to practice, and we build out the tiers in terms of making sure that we take that knowledge and then apply it further, and so that it brings the benefits of that practice, and the framework are that it'll bring research into practice, And this has been developed from over 30 different behaviour change theories and frameworks. And we're really finding this very helpful in our work. In terms of, we had a summer project that we looked at the impact of the virtual appointments of children and young people and how they communicate with their care providers, and that's both general practitioners and nurses. And some of the things that our young people said, we are so often about what we want, but it doesn't make any difference. And so as a result of that, we thought if we try to build them into our work, communication team that enables us to get this dialogue that is so crucial, so that we learn and we communicate and listen carefully. And so what the young people were saying, they wanted to be able to send texts and questions and get them back, the answers back. And they said, businesses do it. Why can't the National Health Service do so? And so we've been working with them. There's a clip that I won't try and show because I know my internet connection is not strong enough. But if I've left the clip, the YouTube link is here, so that please do have a look at it, and you'll see some of the things that they're doing. And if communities don't see what's being done, they start to lack trust in us. And what we have found is that we've often in the past not fed back to our communities, and that's where services begin to fail, because it leads to apathy and people just saying, oh, you're always asking us questions, but you don't ever do anything about them. So we need to learn from that and do things together and not make the same mistakes over and over again. So in terms of what we're trying to do with our community research is to look at how we can get community-led health improvement with insights that come from our communities, and so that we get delivery mechanisms that actually work. And so we know that in order to do this effectively, it has to be coordinated, and that we need to make sure that we're supporting and empowering community partners in that process in a way that they feel part of it and not being done to, and not a patronizing approach to this work. And that's why the power dynamics are so important. And we're looking at new models to undertake some of that work. In my past, I worked in developing countries, and I've found that many of those models that I worked with when I was working in that are ones that are new to the UK in some respects. So I think there's a real positive aspect to how we can work between countries sometimes as well. And so I was really interested in hearing what Gabriella had to say, and I would love to be able to see how we might link some of our work together. So if you remember Arnstein's ladder of participation, I would like to see that we have a community-led health improvement that can be seen in a ladder in the same way, where information sharing is at the bottom of that ladder. So we gather information with them together. And then the next step being the two-way dialogue. And that we end up with having a situation where we have peer-led behaviour change interventions that are based on what local people understand and want. And then we have a possibility of doing so much together. So that's my presentation for you. And let's come back.
Thank you, Dr. Marian. That was really an excellent presentation. Thank you. questions for Dr. Moria? Our next speaker is Dr. Kalu Aja. He's clinical fellow from King George Hospital, Ilford, UK. And he's going to give a presentation on insecurities and dogs, an obstacle to the eradication of dracunculiasis. And I request Dr. Kalu Aja to start his presentation.
Thank you very much, Dr. Marin, for your wonderful presentation. Hello, everyone. Thank you to other speakers, and thank you to other delegates and students. I'm going to share my screen. Okay.
Yes, we can see your screen.
Can you see? Okay. So let me start the slide presentation. Okay, so the title of my presentation is Dracunculiasis in Endemic African Country, and Insecurity and Dogs, an Obstacle to Eradication. My name is Dr. Kalu Aja. And I'll be going through the following outlines. I'm talking through the background, the epidemiology, the life cycle and transmission, impact, current programs, current interventions, timeline of dracunculiasis, the challenges faced towards the eradication of this disease, and proposed intervention and conclusion. A bit of a background, I'm a medical doctor with a master's degree in public health from the University of Chester. I'm currently a clinical fellow in care of the elderly and acute medicine, King George's Hospital. My interest lies in developing healthcare policies and innovations to improve current practices in patients' care and also reducing health inequalities in developing countries. We have this saying, sorry, let me go back. The war on Guinea worm, sorry, okay. So the war on Guinea worm will be won by village to village combat. The worm will judge the quality of our work this year. This is a quote from the World Health Organization. So as a bit of a background, dracunculiasis is a parasitic worm infection, also known as guinea worm disease. It's caused by a nematode called Dracunculus medinense, and it belongs to a peculiar group of communicable disease named neglected tropical disease. This group are often forgotten, as the name simply implies, neglected, because they majorly affect tropical countries, Third World War. So many a times we often forget that these diseases exist. And the peculiar thing is managing this disease just simply needs public health interventions to be applied to them. And this disease has been recorded for quite a long time, as it's been identified in even Egyptian mummies. And the epidemiology, about 30 years ago, guinea worm was really prevalent, and it was predominantly in 20 countries, with 17 of this country from Africa. However, there's been a drastic decline in the incidence of this disease from approximately 3.5 million cases. And currently the 2021 updates revealed 4 confirmed human cases globally, a fall from 54 reported cases in 2019. However, a total of number of 13,290 cases are rumored or suspected to have dracunculiasis infection. And there are still countries that are still plagued with this disease, and they are Chad, Ethiopia, Mali, and South Sudan, all in Africa. And in addition, we have about 1,454 dogs which are reported to be infected by this disease. And this is an emerging epidemiology that we've not experienced before. Given this, we have about 198 countries which have been very successful in eliminating this disease, and 7 countries are yet to be satisfied free from this disease. And we have the ICCDE, which is responsible for satisfying this disease. And we can see on this graph, this from 2017, the number of cases, and we can see a jump from 54 to 54 in 2019, and also a decline in 2021. But with the COVID and with a lot of things, follow-up and monitoring process has really been hindered. So this is just the value we have as at the last updates they had from the various countries. So how is this disease transmitted? And it is transmitted by drinking water, contaminated by the vector, which is a copod and is also known as water flea. And this larvae, they emerge from the gastric juice in the stomach and penetrate the connective tissue of their hosts. And the female migrates to the lower limb to through the skin to shed the larva, and the individual experiences very excruciating pain and itching during this process. And usually they go to immerse their legs in water sources, which are also the water source responsible that the villagers usually drink. So that's the circle there. We can see in this stage 4, the larva being shed or released into the water source, and it's been taken up by the copod. And an interesting thing is a different cycle, which fishes can also ingest this water flea, and humans which are in that village could also get this fish. However, with cooking, they could kill the worm and the larva and everything. But with poor sanitation, the guts of this fish are being dumped or not properly disposed. And we can see scavengers, which are dogs usually, they go around the various dump and they scavenge for this fish. And that's why we're seeing a new transmission, because one of the important factors why this disease was targeted for eradication was because humans were the only hosts. But we're seeing a change in, or we like to say an evolution in this disease, because now it's also dogs are being infected. And with humans, you can usually control, but with dogs, it even poses a more harder or stringent challenge towards eradicating this disease. I'm going to explain that more in details. And these are the authors that this disease causes to the hosts. So what's the impact of this disease? As we said, majorly affects countries in tropical region, and majorly they are, their main source of livelihood is usually farming. So this disease, as we said, affects the lower limb and incapacitates these individuals for even longer than the time they have this illness. And also it shows some seasonal variability. So take, for example, a community where their major source of food, of income is farming. You have them being affected, especially the males who go unshod without wearing protective footwear. You have them being affected by this disease, and that affects the labor force of these individuals, and also affects their productivity. It reduces the food, their capacity, and decreases revenue, and this in turn causes poverty. Also, children are also affected because children, they also suffer from this debilitating sore on their legs, and most of these children, their schools are located in maybe the next village, and they have to walk several distances to go to school. But as you can see, this child, because of this sore, can't walk. Invariably, it affects the education of children, and as well as the literacy rates, which are vital factors for community development and intervention. As we will see that health education and education is one of the strategies that have been used for this eradication. And when these children, when you have literacy rates that going down, these children are not able to, go to school, have good education, it in turn affects the community. as well, or at large. So what are the programs that have been put in place for Guinea worm disease? We have the Global Guinea Worm Eradication Program through concerted efforts by the Carter Center alongside WHO, UNICEF, CDC, and the Gates Foundation. We also have other parallel programs, as we saw that water drinking, provision of potable and safe water is also important in the transmission of this disease. So a program such as International Drinking Supply and Sanitation Decades affects the Guinea worm transmission, and we can also see the Global Network for Neglected Tropical Disease Control and the International Commission for the Certification of Dracunculiasis Eradication. So this disease was targeted for eradication by 2015. However, we're still seeing this disease. And this disease has like some peculiarities to it in the sense that it requires no drug and vaccine. So just comparing it to something like COVID, where they had to go to look for a vaccine to prevent it or look for medications. But it's so, this disease it has a peculiarity because simple public health measures can be put in place to eradicate this disease. And that's why it was put as a top priority and for eradication. Also, you could use, as I said, simple public health methods like case containment, active surveillance, provision of safe drinking water and boiling, and treatments, which water treatment, which can kill the water flea, and provision of water filters. These are very simple and cost-effective methods, and which public health centers around. Also, health education and promotion of health promotion to influence behavioral change and community participation, as like, for example, having village volunteers. When the eradication process is coming from them, you know, when the program is being instituted by a familiar face, you see that that community will respond much better. And also cash reward, which are like incentives, which will also help. So when we're talking of the term eradication, what do we mean? It's the permanent reduction to zero of the worldwide incidence of an infection caused by a specific pathogen established in a human or animal population as a result of deliberate efforts with no more risk of reintroduction. And thus far, the only disease that has been able to achieve this is smallpox, pox, and rinderpest. I'm sorry, and this with Guinea worm, as I've earlier said, the eradication program employed a variety of simple but effective public health methods, such as community-based intervention to educate and change behaviors. So we're just going to be looking at some of the methods. The first is just a very cost-effective, simple tool, which is like a water filter. Children, when they go to the stream with their parents, they also drink. But that water filter is just like a rod, and it has a mesh. So once they drink with that, and you can see the tie around their neck, once they drink with that, that helps to filter the water and prevent the water flea from coming, which is one of the cost-effective methods. The picture in B is one of the containment centers in a community. As we said, most of the time when the worm is emerging, the individual wants to go to water source. But once they are put in this containment center, they can be monitored. C is one of a villager who is a volunteer educating children about the disease. And D is just water filtration using a mesh to ensure that their water is safe and potable to drink. And this is a timeline, as I said, it was a disease that plagued mostly Africa in the early 90s. And we've seen a drastic drop because of all the interventions that have been put in place. So what are the obstacles to this eradication? as we said, it was targeted for 2015. However, we're still seeing the disease still around with us. So what are the things that have posed as a challenge? Insecurity, especially with African countries, we're seeing wars, insecurities, civil unrest, displacement of people, and all this puts pressure on those surveillance programs. It destroys healthcare system. It frustrates the donor efforts and causes the displacement of people. When we have war, when we have civil unrest, people are displaced from their home. They don't have access to basic life amenities. They don't have access to water, good water supply. They don't have access to good food, housing. All this puts pressure on all this eradication and strategies. And as we've seen in Chad, South Sudan, Angola, Mali, Ethiopia, political instability, social inequalities, and the infection of dogs have posed a threat and an obstacle to the elimination of this disease. And as I said before, it was looked at humans were the only host, but we're seeing that dogs, you know, dogs are meant to be our best friend. But in these communities, these dogs are not well looked after. They, as I said, they go scavenge, eat the guts of fish that have not been properly disposed, and they have access to the water bodies, infecting and, you know, continuing to continue the transmission and life cycle of this disease. And we can even see the villagers in here trying to extract the worm from a dog. And other challenges have been lack of clean water and safe water in remote villages, poor environmental sanitation, as I said, and these have propagated the transmission of the disease. Guinea worm disease has persisted and thrived because of social inequalities, and in turn exacerbates this inequality, creating a vicious cycle which has a detrimental effect on the endemic communities. So what are the proposed intervention? The good thing about this disease, as I said, it just needs public health intervention. With public health, you tackle it from the source. It's usually cost effective. It involves community participation. So what do we need to do? We need to go back to the drawing boards. We need meeting at strategic levels by policymakers, stakeholders to address the current challenges being faced by the eradication program of Guinea worm disease and ways in which we can maximize the impact of the intervention to meet the set objective. Also, as I said, if we can address the wider determinants of health, such as poverty, insecurities, education, provision of clean water, and environmental sanitation through political will, good governance, and proper policy implementation. This will help to build a solid intervention and foundation for any intervention to succeed. And this is clearly lacking in those endemic countries. Also, we could use approaches. We could use various approaches to tackle the eradication, the obstacles to the eradication of Guinea worm disease. As we all know, the vertical approach just centers on various programs. For example, we have the Guinea worm eradication program. It's a vertical approach because it just targets Guinea worm. We have other programs such as rollback malaria. All this just target specific disease. And we have also the horizontal approach. As we all said, we need to utilize the community. And one of the easy access to any community-based intervention is through their primary healthcare system, which is an horizontal approach, because it not just only centers on a particular disease, it cuts across various diseases, it touches immunization, it touches environmental sanitation, good food, so many things. And when we combine both the horizontal approach and also the vertical approach, which is like a diagonal approach now, so we're strengthening our primary healthcare system, which also involves the surveillance, reporting, and also consolidating the current interventions for this disease, such as the Guinea Worm Disease Eradication Program. That's in the sense as together it's going to improve and amplify the efficiency and the outcome of the intervention. So also we need to go back and have more research into the evolving epidemiology of this disease, as the infection of dogs are on the rise, and putting a halt to this. And due to the changing epidemiology and variation in the mode of Guinea worm transmission, changing the intervention indices like reward awareness, abate coverage, and burying fish guts, providing safe water and accessibility will help combat the challenges in opposing eradication. So as I've been saying, that this disease is peculiar because it's a disease in which simple public health measures can be put in place to help eradicate this disease. So in conclusion, dracunculiasis represents a disease that can be eradicated to join smallpox without a drug or vaccine, but with cost-effective intervention that involves both the government and community efforts in tackling the problems created by insecurities and infection in dogs. So why I picked interest in this disease, as I said, is a disease targeted for eradication, and it doesn't cost so much to eradicate, because what we just need are simple public health measures. And by implementing all this, we've seen the success over the years, and we've seen a drastic decline. So what we need to do is to press on. We need to, engage the community more. We need to go back to the drawing board to look at this evolving epidemiology with the rise in infection by dogs, and we have to tackle this. And also with insecurity, it doesn't also just affect Guinea worm, it also affects all other issues with the community. So thank you very much. These are the references, and thank you for listening, and if you have any questions, I'm happy to take them now.
Yes, thank you, Dr. Kaluaja. It was really awesome presentation. Any questions for Dr. Kaluaja?
Hello.
Yes.
I'm from India, and I just wanted to know that are there any cases reported in India about the Guinea worm infection?
Mm-hmm. Sorry, I didn't get the question.
Do you know of any cases reported from India about Guinea worm infection?
Okay, so as at the moment, there's no any case reported in India. The cases that Guinea worm have been reported are just majorly in Africa. So we have Mali, we have Ethiopia, we have Chad. So India is not amongst the country that have Guinea worm at the moment.
Thank you. Thank you very much. It was a very good presentation. We enjoyed it.
Thank you.
Any more questions? Our next speaker is Dr. Kenneth Ryan.
Can you hear me?
He is a public health infectious disease epidemiologist, health science, public health professor from United States. And she is going to give a presentation on vaccine hesitancy during an pandemic for a frontline epidemiologist perspective. And I request Dr. Kenitra to start her presentation.
I can't hear. Okay. Can you hear me?
Yes. Please start your presentation.
Okay. So let me share my screen.
Yes, please. Please.
So I
share
can't
it.
hear back if you're talking.
Please share. Continue. Continue, please.
Yeah. Please, did you see my screen? Let me try
No.
again.
No,
Hold
no.
on. Let me
Not
see.
yet. Yes, yes. Please start.
Okay. Let's do it. Okay. All right. Hello, everyone. Greetings. I'm Dr. Kenitra Young. I am a public health epidemiologist, and I have worked on epidemics and during the current pandemic. So I'm going to speak about a couple of those. Since I am a professor, I talk as one. So when I give demonstrations, I go to the basics first because I never know who my audience is and what they know. Excuse me. And I know that people have been talking about epidemics and pandemics throughout the day. So this was just giving basics for those who did not know what an epidemic and a pandemic was. And people use these words not correctly in a scientific way. And so when I hear it, and I just politely correct them about what it is. So just real quick, epidemics such increase in number of cases or disease, but what is normally expected and what is usually is expected or has occurred. And a pandemic refers to an epidemic on a global standpoint. So that's when things cross international borders. And there are many notable epidemics and pandemics that have occurred in our lifetimes and beyond, and many centuries away, long time ago. So I'm just gonna touch on a few of those. I'll just have a few of these that's highlighted here for those individuals who may have heard of them before, because there are other ones that people never have heard of. And so what's this one? HIV/AIDS, Ebola, yellow fever. And of course, there are other types of fevers that have been out there. The plague, the bubonic one I pointed out here. You have the swine flu. So that has occurred recent times. The Spanish flu. It's not as recent, but because this is the 1900s, but this is what has been looked at a lot to help us deal with the current COVID-19 pandemic, to see how we did handle the Spanish flu when it did occur. And I highlighted hepatitis A and COVID-19 because those are the ones that I would specifically touch on. And these are the ones that I have worked in the field with. And so before I go into those, I just want to talk about the vaccines, because that's the reason for my talk. And so when I do talk to people, I do discuss vaccines and why we have them, why we need them. And so I tell them how they were developed to protect us from contagious diseases, from communicable diseases. And then when people ask, oh, like what? And then I'll go and talk about smallpox and how deadly that was, and it overwhelmed the world. It impacted the world greatly. And so we needed the science to help us defeat that. And so I tell them how its morbidity and the mortality rate was very high. And then sometimes I would show pictures on it to see what they look like. And so for instance, in the US, we had a recent case of monkeypox. And then people say, have you ever heard of that? And I say, yes, I have. And they have to give history on things. And then I tell them that every country is impacted in different ways. But right now, we're all impacted dealing with the COVID-19 pandemic. And then I tell them how smallpox was eradicated. So some people will ask, they ask the science, they ask the in the community, they say, will we ever get rid of COVID-19? I said it's possible, but we have to do a lot of work with it. And one of those things is getting the vaccinations. And so we have childhood vaccinations has helped significantly in the United States to reduce the incidence and prevalence of many diseases. And when we do see the diseases, again, it's a lot of times because of people come from different countries who does not have adequate vaccination efforts. Then if we have people like within the US who are considered anti-vaxxers, meaning that they do not want to vaccinate, and it's different reasons for that. I will talk about in my slides about vaccine hesitancy. I'm gonna talk about specifically about what I've heard in the community when I was in the field. And I'll touch a little bit on the other anti-vaxxers, but it's just the ones in the what I have seen. So when I was in the field, because in Michigan, we had a hepatitis A outbreak, and a lot of people thought about hepatitis A with kids, but a vaccine was developed years ago to help with the kids. But it was the older population who did not have a vaccine because it wasn't developed during their childhood. So we had saw an increase in hepatitis A disease, and we had to figure out what was going on. So we had to target the high-risk population that it was impacting. And that population was inmates, people that was in jail, it was the substance use abusers, it was the homeless population. And so when I put efforts to help combat this disease, I had to go to those places. So I had to go to the homeless shelters. I had to go to the jail and give education. I had to go talk to the infectious disease physicians. And so it was about talking to people, partnering with people to help combat the outbreak. And that turned to an epidemic, and there was many states within the US that was impacted by this. And we dealt with stuff. I was in California when they had theirs. I was talking to their public health officials. I was seeing, so you have to do the research and talk. And a lot of these things, when they went to the pandemic, a lot of these things that are listed now is what people have said about the reason why I don't want the vaccine. And so I'll talk about these, and then I have another slide about it. So when the hepatitis A epidemic was going on with this, some people didn't know what Hep A was. They thought they already received the hepatitis A vaccine because they confused it with a different vaccine that they previously had. And so education had to be done around that. Some people thought it was a hepatitis B vaccine. Some people thought they got a hepatitis C vaccine, and I would tell them that doesn't exist. And there was a lot of things that has been done better with hepatitis C, and then it's medication or whatnot. So the thing is, it's all about educating people, figuring out what their concerns are. And sometimes they just don't know. A lot of times being one-on-one with the person and addressing their concerns is very paramount. And so that helped a lot. I had noticed that the inmates, they would get and so then it was where we had to put efforts to make sure that the systems talk to each other. Some people just dislike the government. And then they say, oh, I'm not gonna give that. You're probably giving me expired vaccinations. Those probably not safe. You're probably using me as a guinea pig. And a lot of times that goes to their fear of experimentation, and it goes back to history. And so here in the United States, it goes to the Tuskegee Project, which was the syphilis experiment. And that happened in the 1930s. And by the time it was discovered, it was like 1970s. So it lasts for many decades and for a long time. And people remember that. And so it was many people that told me about this. And they said, no, because of the experiment, you're trying to experiment on me. And some people know about experimentation that has happened in other countries. So they fear the vaccine might worsen their comorbidities because some people had other disease states, they had other stuff going on. And so they'll say, no, because that'll make my diabetes worse, or no. And then when it comes to the infectious disease part, they say, no, I cured my hepatitis C. I don't want it to come back. And so if I take that vaccine, it's going to make me sick. And so education had to go around with telling them, no, that will not happen. You will not get sick, and just giving them the pros about taking it. So with the current pandemic, people will say that it's only used for emergency and it's not federally approved. So why should I take it? A lot of people say the disease is too new and constantly changes. So how do you know that this is good, that it will work? People and the side effects. And so it's when I educate people, and I talk about the flu vaccine, because a lot of people have those concerns and they don't want to take the flu shot because they think that it's going to make them have the flu. And then I have to educate about that. Okay, it's different. It's a cold, but you technically get the flu. And then some people have a lot of medical allergies and they're just scared to do it. I have some people who are, when it comes to more of the pandemic, the COVID-19 vaccine, they've said to me, like, I'm leaning on my spiritual beliefs and my religious beliefs, and God will protect me. And if I get it, then I get it, and that's it. Then you have other people, despite the statistics that are out there across the globe, within their own states, their own community, they still do not believe it will happen to them. And so they just think, no, I'm not gonna get it. And then it's just the opposite of people who have had it and recover from it. It's opposite of people who have lost family members, loved ones to the disease. Those individuals have been, because they have seen how it can impact a person, they have been more apt to get vaccinated, and they bring other people with them to get vaccinated as well. And so when it came more with the hepatitis A vaccination efforts with the epidemic, I was able to, with the places I went to educate, I was able to talk to people, in like a group of people who did not want to get the vaccine. And then I was able to address them one-on-one what their concerns were. And that helped a lot. And with some of those people, they did say, okay, I understand now. And then they did get the vaccination. I have some people I noticed when I was in the field that they had literacy issues, and sometimes they was embarrassed. They didn't want to fill out the consent form or fill out the information because they didn't want to expose that they couldn't read. They didn't want to expose that they didn't know some of their information, some of their health information, or if they had issues. So people have to be sensitive to that as well and figure out what really is the person's concern. So I know this says conclusion, but that's because I knew that I was going to talk a lot without the slides, but I have a few more minutes. So otherwise, I say that decline in new cases is only observed as the number of monthly vaccinations are administered. It's a way to look at the daily administration rate. It's a way to look at weekly, but when a monthly adult vaccinations are administered 10 times past the baseline rate, that's when, especially with the hepatitis A, we start seeing a decrease in the epidemic aspects. It's important for robust epidemiologic support to drive the innovations, the partnerships, the strategic responses to address all those challenges. That's really important. Not one person can do this. It takes a team to do this. And with the pandemic, it takes country to country to do this. During the epidemic, we talked state to state. I went like in other states to give presentations to certain conferences in states that wasn't experiencing the epidemic yet. But then later they did, because it's just how the disease ended up traveling with the people. And so the other states were involved with the epidemic. And right now, in our pandemic, it's the world. And to eradicate it, we need to go back to history, go back to what was done during the smallpox and how did that work? And it took years for that to be over. So we're in our 1.5 years and going to our 2nd year, but I believe with more partnership and responses and just understanding the science and people trusting the science, that's how we can combat this. And so with our lessons learned, find those high-risk individuals. We need to staff and clinic resources. They need to be maximized. We hear that a lot in the media. We need to do more. The reason for the low number of attendees or low uptake at certain facilities should be analyzed. Figure out why, ask the why questions. Establish relationships with hospitals. And for us, what I have noticed with epidemic, we have federally qualified health centers in the United States. That was important. So I made relationships with them. I talked to those physicians. I talked to the community partners who service and work with the high-risk populations, because maybe it's a population that you never worked with before. Work with the individuals that have and learn from them and work with them. Be at certain events and meet the individuals. Mitigation disease impact through effective primary and secondary prevention strategies is paramount. And so we need to do that. It's so valuable. So I'm looking at my clock. So I know I have until 12 to 1 more minute. So I want to thank you so much for your attention. I know I had some technical issues and I'm sorry I was a couple minutes late, but do you have any questions for me? I can't hear nobody probably though anyway, but just let me know, put in chat. I'll make sure that my information is given. So if you have other questions that you can't think of right now, then you can just tell me, but thank you so much.
Thank you, Dr. Yang. Can you hear me? Can you hear me?
Refuse to get vaccinated because they are sick and recover from the infection. My take is to still do it because they don't have enough antibodies. It's not proven. So in my family, my mother, my sister, 2 of my nieces all contracted COVID-19. And I was the person who went to the pharmacy to get them like medicine in terms of if they had like a sore throat because they coughed too much. It was no medicine to treat the virus, but it's medicine to treat certain symptoms. And so I the one who went to the store to get them something to drink or food, but they lost their sense of taste and smell. And so they would say, oh, could you get us this? Because we can't taste that. And I would do it for them, but I would tell them like, the reason why you can't taste this because you have the virus, but I took them to get vaccinated and they was okay with getting vaccinated. They know how it felt to be sick and they did not want to be sick again. So I would tell people who had contracted the virus to still get the vaccine, build up more antibodies.
Can you hear me?
You think
Dr.
Kenneth,
can you hear me?
Vaccine hesitancy?
Dr. Swapna, I think she can't hear. Can you please ask her in the comment section?
And your opinion. I do believe we will eventually overcome it. We have people who are anti-vaxxers who just don't trust medicine and may have heard of one person who got sick from something, and then they think, oh, that's every vaccine. I have encountered people who like will vaccinate against one childhood disease, but not all childhood diseases. So I do believe we can overcome it. And the main way we can do that is by getting rid of the myths that exist and concentrate on the facts, and to say that a lot of things happen historically that would not happen now. And that's why we have a lot of things in place to make sure it doesn't happen. So just try to tell them to don't believe that, believe now versus the past. We learn from the past so we could do better in the future. So I do believe we'll overcome it. It'll take time, but I do believe we will. Other question, any advice on vaccine confidence, education, and prison, detention inmates, any professional advice? Appreciate it, sure. Taking into consideration the points made, the moderator is trying to talk to you, you cannot hear him. Yeah, I can't hear nobody. So when I went to the prisons to talk to the inmates, it was with a lot of them, because a lot of the prisons where in the United States, they have nursing stations, like nurse department where they'll go around to the prisoners and have them get vaccines or whatnot. So with that, it was talking to them, because everybody had a different educational level. Some of them were younger, there's like probably 18, and maybe another person was 70. And so when I went to prison, just talking to them about the basics, giving them understanding with them, I also gave them something to read. So it's about talking to them and making them feel like they are important. Some of them didn't feel like they was important, and we really didn't care about them. And there was part of some of the groups that like, oh, you just experimented on me. And I would dispel that myth and just tell them. So I also had to work closely with the jail administrators, with the physician who was the person who was in charge, the nurses, and talk to them and see what the issues were that I should address more. And a lot of them, and when I went to the shelters and different places with the men and the women, with a lot of them, they did think about their families, they did think about their kids, they did think about how stuff would impact them if they didn't get it, if they would get it. So just talking to them and figuring out what they needed. So yeah, so it's working with everyone that's involved, working with the administrators and talking to them like they are important, talking to them like they do mean something, because some of them didn't think they do. So yeah. Tuskegee. Yeah, so the thing is with Tuskegee experiment, it was people during that experiment, people thought that they was getting treatment to cure the syphilis, and they wasn't. And so that's why that goes into play. So they people with the vaccine, they thought that with people who refer to the vaccine, they say, oh, you're trying to tell us this vaccine will work, but maybe it doesn't work. Maybe it's just water in there, or maybe it really isn't. So that's where that comes into play. They don't think it's really the medicine in there. Okay, so some people don't want to get vaccinated, okay, in your country because, oh, that particular vaccine efficacy is low, which seems to be the only vaccine available in Africa. My take is there are, in the United States, we have Pfizer, Moderna, and Johnson & Johnson. And the Pfizer and the Moderna are 2 shots. The Johnson & Johnson is 1 shot. The efficacy of that particular vaccine is not as high as the 2-shot vaccines. And I have heard about the vaccine that you are experiencing. I would hope that we get to where we have the same vaccines that we are using across the globe, so that we all can respond to it the same way. And so, but I know that different countries all had a different reasons why they choose the vaccine. And I hope that more vaccines will come available. And so like the vaccines in the United States, we've been, the efficacy for those two with the Moderna and Pfizer are in the 90th percentile. Johnson Johnson is 70th percentile, but it's still effective. So I believe it's going to take time, but I believe we need to do that. So I hope that more can come to the other places. Was totally, yes. The skiing project was totally ethical practice, which is different from the vaccination drive. Yes, it is, but no, people still remember it. And so despite the fact, so for instance, my camera don't look as clear, so I don't know what happened, but okay. So for instance, they think about that. And so because they know about it, read about it, and may have certain people who was alive during that time, they remember it. And even in doing the, I heard that a lot when I was doing the Hep A vaccination efforts, but during the pandemic, people still bring it up. They just still bring it up. And so the problem was that it was unethical. And then when the government allowed it to go on for so long because they didn't know about it. And so people still bring it up, and it's still a fear for some people and a reason why they do not want to get vaccinated. And so when I hear that, I just tell them it's a difference, and I explain the difference. And so those are the ones that I could talk about when they bring them up. Then when it comes to stuff that happened in other countries, people say, oh yeah, in other countries and doing what happened in Germany or doing what happened in such and such. So they'll bring them up, and people love the internet and they be on the internet, and then they'll bring it up again. So I always tell people to look at reliable sources, look at scientific sources to address their concerns. Let's see, I'm gonna make sure I didn't miss. You're welcome. I don't think I missed any questions. If I missed your question or anything, please put it back, but I think I got everybody. Are there any more questions for me? Let's see.
Thank you, Dr. Kenitra. Thank you. It was really awesome presentation.
Yeah, so build up the confidence. Tell them, people like the stories. I believe in the art of storytelling. So tell them the good stories. When they bring up a bad story, then just bring up the positive stuff again and let them know. So it's some good, it's greatness out of all of this, and we'll eventually get there. So.
Thank you.
I don't think it's nothing else. I know we probably have another presenter now, so Shiva. I can't see, I can't hear, so just type to me.
Okay. Thank you so much. It's
okay.
Moving on, our next speaker is Subarna Chakrabarti.
And I'll log back in during the
Subarna Chakrabarti from Imperial College London, United Kingdom, and she is going to give a presentation on understanding the role of digital contact tracing tools during COVID-19. And I request Subarna to start the presentation.
Awesome. Is everyone able to see my screen?
Yes, please continue.
All right. Yes, are you still able to see my screen?
Yes.
Okay. All right. So hi, everyone. Good afternoon, good evening, good morning, wherever you are based globally. So my name is Subarna Chakraborty, and I'm currently a public health student at Imperial College London. Now, my topic looks at understanding the role of digital contact tracing tools during COVID-19. Now, so we know that, in late 2019, the novel coronavirus was identified in Wuhan, in China. And so even before, the existence of the novel coronavirus, in general, the Coronaviridae family has been responsible for causing pandemics and epidemics across the world. Cases in point being the SARS epidemic, the MERS epidemic, and So we are basically dealing with the Coronaviridae family once again. Now, as of 2021, there have been over 199 million cases and 4.24 million COVID-related deaths worldwide. So that's how huge the burden of COVID-19 is. Now, the COVID-19 burden also increases to other aspects of one's health, for instance, mental health. And because of restrictions and because of practices taken by the government and other public health authorities to curb the virus, it can and has been affecting the depression and anxiety and other related mental health disorders within certain people. So as of now, the burden of diseases currently vary from region to region, but about 80% of these new cases have been recorded in the Americas and Europe, and that accounts for about 80% of cases and deaths globally. Now, briefly looking at the symptoms of COVID, so we have fever, throat pain, runny nose, loss of taste and smell, and to your left, you'll be able to concurrently see that these are some of the methods or ways of preventing, or if not preventing, at least mitigating the chance of one contracting COVID. Now, here is one of the most interesting things that I am looking at. I am looking at how we can also consider the role of contact tracing. Now, contact tracing is something that has been practiced by public health practitioners for a very long time. Now, whether it has been the Ebola crisis or any other disease before this, role of contact tracing has been crucial in mitigating or even eradicating the chances of the spread of diseases. Now, in most countries, in most low and middle income countries, the internet is not a ubiquitous resource, and neither are mobile phones. So therefore, mostly in low and middle income countries, we resort to manual contact tracing. Now, manual contact tracing is carried out, by interviews and phone calls, and this is traditionally done through interviews. And this is how contacts are identified, and then they are traced back, and then they are warned and spoken to, and are asked to quarantine. Now, although it sounds feasible on paper, we need to understand that there are certain regions associated with contact tracing where it is not very easy to reach to certain destinations. And secondly, contact tracing is also a very labor intensive process. It also, you basically are sending out contact tracers to different locations to talk and to find out. Now, apart from the fact that it is labor intensive, you may also have other cultural, religious and language barriers, which would make it very difficult for one to resort to manual contact tracing. Now, for instance, when the Ebola outbreak had happened in the Sierra Leone and other regions of West Africa, many cultural and there are a few cultural practices which resort to burying of victims. And therefore, when such a cultural phenomenon is practiced, it becomes very difficult for contact tracers to warn grieving members of the family, and even more so because of the contagion, because of how contagious Ebola was and continues to be. Moreover, we also need to look at resources. Now, manual contact tracing is not exactly as resource effective, and it's not sustainable, because you are using a hefty amount of paper, and you're using a hefty amount of transportation and logistics that are associated with performing manual contact tracing. And even after performing all this, it doesn't necessarily ensure that you are actually getting your primary, secondary and tertiary contacts that may have come close to somebody who has been carrying the disease. Therefore, what I am looking at is the use of digital contact tracing. Now, although digital contact tracing is a very feasible option, we need to understand that the WHO had set a benchmark. Now, it had basically said that successful COVID-19 contact tracing operation is to trace and quarantine 80% of close contacts within 3 days of a case being confirmed. Now, this is a goal that not many countries have been able to achieve. In fact, even studies from University of Oxford suggest that even 3 days is too much of a time span for one to actually digitally contact trace and find people and ask them to quarantine, because even by then you still have a very good chance of at least secondary spread of the virus. Now, what I want to emphasize is on a few countries that have implemented digital contact tracing and have actually seen results. Now, although there are a few controversies or rather, a few qualms that could be associated with the way these countries have practiced contact tracing, but it has worked for these countries. Now, my examples over here are South Korea and Vietnam. So what happens over here is in the case of South Korea, now they use data surveillance techniques to get around people who are unwilling to share information pertaining to whether they have or haven't contracted COVID, or if their family members have or haven't contracted COVID. And obviously, when there is a panic associated with a pandemic, people are skeptical and hesitant to talk about them contracting a virus like this, because obviously there are rules and government guidelines associated with how one must be treated in where they are resorted to quarantining, etc. So therefore, what South Korea basically has allowed is that their personal data such as credit cards, mobile phones, and closed circuit televisions are basically used to trace a person's movements and identify others who have been exposed to the virus. Now the problem here is, in the case of South Korea, this information is published online, and because of this, a law was passed by the country to make sure that too much of information is not given out by the Ministry of Health, because this is a violation of one's privacy as well. Now, similarly, in Vietnam as well, they also use more data surveillance techniques, which basically picks up at your digital footprint in social media platforms like Facebook or Instagram, and they also use your mobile phone location data. Now, similar practices have been used in other countries, including Israel, Armenia, Taiwan, etc. Now, a similar practice is also done in other places, such as the UK through the NHS contact tracing app, but in the NHS, you use the Bluetooth of the mobile phone, as opposed to digging this deep into one's personal life, etc., for surveillance. Now, what I want to focus on is one particular tool that could be used for digital contact tracing, and this is a very secure way of dealing with the problem and the qualms of how one can protect their data, and also to make sure that you do not dig this deep into one's personal life to make sure that you are practicing data surveillance and also maintain contact tracing. Now, I want to divert your attention to blockchain. So with blockchain, there are a few tenets associated. Now, you need to understand that you basically do not have too many third parties involved. It is completely digital, and everything is cryptographically encrypted. It is stamped, and therefore whatever is associated within the blockchain, it is basically real life data, and it is updated on a real time basis. Now, the blockchain technology is very, very simple. So basically what happens with blockchain, just a moment, I apologize. I just realized that I hadn't put my slide on slideshow. Yes, right. So with blockchain, it is a very simple data. Although blockchain initially was used in the finance technology industry, this was the first generation of blockchain. Now currently you have the third generation of blockchain that basically associates and is used in healthcare. Now, a blockchain is a very simple technology that is associated with one's ledger, and it basically makes and is basically connected within a network of people. So whenever there is an information that is updated within the network, that information is shared only within the close network of people. So basically now if one were to input data pertaining to a patient's information, that information would stay within that network, or that network could be a government institution, or it could be a hospital, it could be another stakeholder or a group of stakeholders who are dealing with that information. So basically this is what we call data transaction. So basically when your data is inputted, it is shared within your peer-to-peer network. Now, once that is done, each of this information is stored in what one calls a node. A node basically also a blockchain. A node is basically cryptographically encrypted. It's within a block. A block basically has a head and a body of which a node is put inside. So each head of the block is associated with another head of the block, and therefore when multiple blocks come together, it forms a chain. Now what happens is when it forms a chain, even if one tries to change information in just one block, it will affect multiple blocks, and therefore the person who is trying to change your information will get caught by the members of the network. And therefore this ensures that data modification, duplication, or deletion is almost impossible within blockchain. Now, when one updates the blockchain, the transaction or a combination of transactions is basically stored as a data. By transaction, I mean the information that is inputted into a block. Now, once that has happened, this data or this information is permanently added into a block. Now, once that happens, that information is stored in a very secure manner. And therefore, when blockchain is used in healthcare, it protects patient data, it protects patient privacy, and it makes sure that this information is stored in a very safe and secure manner. When we look at certain use of blockchain in the field of contact tracing and healthcare during COVID-19, these are just some of the options. You can use them in vaccine passports, in remote patient monitoring, in pharmaceutical supply chains, and also in electronic health records. Now, looking at vaccine passports. So now currently, since the rollout of the vaccine has been very, it has been going on, multiple levels based in the country that you're in. So we need to make sure that, the vaccine, the information pertaining to whether a patient or whether a person has been vaccinated with 1 dose or 2 doses, whether he or she or they have experienced any side effects. All of these information, they need to be stored in a safe and secure manner, and also the type of vaccine that he or she or they have received. So these kinds of information, they need to be stored, and this is a very sensitive piece of information for very obvious reasons. And therefore, with the use of blockchain, Internet of Things, and artificial intelligence, one can make vaccine passports and therefore store all this information. Now, similarly, when we come to the next use, when we look at pharmaceutical supply chains, now through the COVAX initiative, there has been a steady delivery, import and export of vaccines throughout multiple nations that are acting as important stakeholders to make sure that globally the fight for the pandemic, to curb the pandemic is in full force. Now, there are different companies that are working towards developing vaccines. So when we also look at information that are pertaining to clinical trials and real world evidence of vaccines that happen as we go on a real-time basis, this information is again very sensitive in nature, and as Dr. Kenetra had pointed out, when there is misinformation, that causes panic. That definitely does not sit well with people. And of course, when you have media houses associated with information or misinformation, that obviously will not sit well with people. So therefore, again, when you talk about storing clinical trial data and keeping all this information safe, this blockchain is a very innovative approach towards doing that. So therefore, the use of blockchain can also be very evidently used in the pharmaceutical supply chain to ensure that there is a protection of data and also those who are associated with clinical trials. Now, the next two uses are electronic health records and remote patient monitoring. So when we look at the electronic health records, now the information that is given out in electronic health records, it goes beyond your face-to-face, your peer-to-peer consultation with your caregiver and the patient at hand. So, in electronic health records, your information pertaining to comorbidities, pertaining to any information that is relevant, and it doesn't necessarily only have to be associated with COVID. It can be associated with just your general health, and to make sure that you are in good health, both physically, mentally, and emotionally. So this information can be stored in electronic health records, and this is something that can or has been implemented in many healthcare systems within a few countries. And so therefore, with respect to electronic health records, it again protects patient data. And since the blockchain is basically a source of technology that can just keep building itself, and there is really no stop to when one can or should put a stop to it. So the information, it can be built and built. And this information, and this can save lots of save lots of labor. This can save lots of labor force, and also be economical in nature, in the sense that now you will not have to assign a workforce to make sure that this information is updated on paper on a regular basis. You are curbing down unsustainable resources, and you are also curbing down, or rather pushing patients or health caregivers into giving better use of their time. And given how the pandemic has made us understand how important the field of public health is, and how important frontline workers play in ensuring that that the infection hotspots or any area is curbed down, you need to understand that we obviously need to channelize our workforce into better areas, instead of having them sit and update health records. So this is another use of blockchain, where this information is also secure, and it also eliminates the chance of human error. Now, coming to the last use that I want to elaborate on is remote patient monitoring. So now the pandemic has made us realize that it is very difficult to have face-to-face consultations for very obvious reasons. And this is even more pronounced in vulnerable groups such as the aged population, because it is not easy. Since they already can or may carry comorbidities that are associated with COVID mortality or fatality, it becomes very difficult for the elderly to actually have this conversations with their caregivers directly. But at the same time, we need to understand that they need to be monitored regularly, just to make sure that their health is still kept and given importance. And this is where remote patient monitoring plays a very crucial role. So to make sure that you have face-to-face consultations with your general practitioner or with your doctor, and also keep updating this information on a real-time basis, we need to also make sure that we can and use blockchain to the best possible extent. Now, this basically helps me understand and give you all an overview of how we can resort to digital contact tracing and use technologies such as blockchain to make sure that this is something that is feasible and maybe could be implemented on a larger scale. And yes, there are a few drawbacks to it, but I believe that the positives in this case outweigh the negatives. And yes, it may not be completely feasible in low and middle income countries. So this brings me to the end of my presentation, and I am happy to take any questions that you may have. Thank you.
Thank you, Dr. Subarna. Thank you for the excellent presentation.
Thank you.
Any questions? Our next speaker is Dr. Tasnuwa Khan FR from the University of Texas Health Science Center at Houston, United States. She's going to give a presentation on epidemiology of cervical cancer in West Bengal, India, and barriers to prevention. And I request Dr. FR Khan to start her presentation.
Thank you, Naz. Can you see my screen?
Not yet. We can please start.
Hi everyone. Yeah, this is Tasnuwa Khan Ifa. Just a little correction, that is, I am not a doctor yet, but hopefully I will be very soon. So I'm sorry. It started from the last slide. So yes, I'm just giving a little bit background of myself. I did my MPH in public health. In public health and global health and epidemiology. And cancer is one of my biggest field of interest. So today I will be presenting the epidemiological study on cervical cancer in the West Bengal region, and we will see that what are the barriers to their early prevention over there. So I am sorry, I have to doing now. So the outline of the presentation is we will go through the introduction to cervical cancer, then what is the global epidemiology, the risk factor of this cancer, and the overview of this disease in India. The case we'll see 3 case studies and their results, and the current situation of the HPV vaccination in India, and what are the barriers are coming up while implementing this vaccination in this country, the gaps in the study, and we'll talk about the recommendation and the summary. So most of us already know that what is cervical cancer. This is one of the most lethal gynecological cancers in the world. So it is not very much early detectable because the symptoms start out in a later stage. So that's why the prognosis is really poor when it is detected in the later stage. So, but it is very much preventable with regular screening and the vaccination programs. So we will see that still why this is one of the biggest or one of the most lethal cancers after being preventable. So here I will show some of the global epidemiological data of this cancer. So I'm sorry. So cervical cancer is the 4th most prevalent cancer among the women worldwide. Women who are aged between 40 to 60, they're the most mostly affected population with this cancer. So according to data set, we have found that nearly 6.5% cases have been diagnosed so far in 2020, which is like 600,000 worldwide. And for this cancer, 7.7% women have been died so far in this year. So cervical cancer is more prevalent. We can see in this 2 diagram about the global epidemiology, but I did not show the global the geographic distribution of this cancer, but I can say that it is more prevalent in the sub-Saharan Africa region, Southeast Asia, and some parts of Latin America.
Mr. Snooper?
Yes, ma'am. Yes.
We can't see your screen.
You cannot? now, ma'am?
Yes, yes, yes. We can see the screen.
Okay, okay, I'm sorry. Somehow it got disconnected. So yes, as you can see in this pie chart, that is, it is already showing that it is the fourth most prevalent cancer. And as I was saying that it is more prevalent in sub-Saharan Africa, Southeast Asia, and some parts of Latin America. And 85% cervical cancer death have been occurred in the lower middle income countries. Okay, so the risk factor of cervical cancers are human papillomavirus, which is called as HPV, and having multiple sex partners, oral contraceptives for a longer time, depend on which oral contraceptives they're using, excessive childbearing at earlier age, too early onset of sexual relationship, and HIV is like after the first one, after the HPV, all other factors are the risk factors, but the HPV is the main risk factor of this cancer. So I would like to say a little bit more about this HPV, which is responsible for 99% of all the cervical cancer, and at least 14 types of HPV can cause cancer, but the serology of HPV serology is 16 and 18 are the most accountable virus, and about 5% of women in the general population are estimated to having HPV all the time, but 83% of them are invasive and they can cause cervical cancer. And the teenager and young adults who are like who are sexually active, from like 15 to 50 years old, they're more vulnerable to this cancer. And approximately 90% of this infection are not really detectable within 2 years of the infection onset. So we can see in this little picture that is HPV is responsible for other cancers too, but it is 99% responsible for this cancer. So, so according to, well, I would like to talk about a little bit about the effectiveness of vaccination and screening for HPV, as I have already mentioned that this cancer is preventable. So according to CDC, we have found that this cancer came down from 11% to 4% from the time frame in between 2003 to 2012 among the young girls in USA, as the prevalence of having the vaccine is more here. And the New Mexico PAP registry showed that the vaccination decreased in the cervical intraepithelial neoplasia to 41%. And another study in 78 lower middle income countries, those studies showed that this vaccination can lead up to like 90% reduction in HPV infection. So the countries who are having high vaccination coverage, they can decline to 73 to 85% HPV prevalence, and it can also decline help to decline nearly 50%, 50 to 57% lesion among the young women. So, and vaccination can prevent up to like 70% of other HPV-related cancers too. So then we will see a little bit about the epidemiology of this cancer in India. So in India, this is the second most prevalent cancer. So we can see that India carries 1/5 burden of the world cervical cancer. It is really high here till today. So the we have found some data. I didn't mention, but it is to mention that it is really difficult finding like state-wise or cancer-wise more detailed data about India. So we have found that cervical cancer is the highest, second highest new cases among the women here in this country. And 18% death has been occurred in last year due to cervical cancer. And from the National Cancer Registry, I have found that the projected risk for this cancer in 2020 was 1 in every 75 women, which is nearly 75,000 women in this country. They are at risk. Okay, so here I'm showing an overall map of India where people means the women are, the prevalence of the women who are intend to take their screening program for this cervical cancer. So as we can see that the northern region, the southern and western region are more inclined to do their screening. They have a little bit better idea about this cancer and they go for the screening. But as we will be focusing on West Bengal side more, you can see that the West Bengal side in this part, the prevalence is really low. It is even like 0 to 15% of prevalence of this screening program. People do not really want to go to their for their screening. So there was a study done by CDC. It was not a very much recent study. It was done by 2015 to 2018 among nearly 700,000 women. They are married and unmarried both. Both groups were there between this age limit, and they have found that only nearly 30% women were inclined to do the screening. Not much, and the prevalence were higher among the educated people naturally, and where the people have like they're affluent, they have a good income, they go for the screening more than the other people. And specifically in West Bengal, the screening prevalence was only 5.2%. It was among like 8,000 people. They have found that only 5.2% are going for the screen. So as I have already mentioned that it is really really tough to get any kind of recent study in this area, not only in this area, even in India too. The studies about cervical cancer is not that much. So there are not very good epidemiological data on this cancer. So here I will be presenting three studies which will give you some insight about the prevalence, the cases, their attitude, or maybe the barriers to the prevention. So this is one study that has been done in 2015. In 2015, among the these are some Bengali women in Kolkata who are students of Calcutta University. So this study has been done among them, and we have found. I'm showing you a table here. So I have marked some points here. It was about their attitude and their knowledge about this cervical cancer. So you can see that these marked areas, like among these, there were like 100 women in the study, and they have showed their thinking process towards this cancer. So they have said that like 27% of these women think that HPV infection is strongly related to this cancer. 40% of them say that, okay, this cancer is related to multiple sex partners. That is also a risk factors. HIV infection or large number of pregnancy. We can see that the numbers are not really very high here. So I'm going to my next slide explaining that where does it lead us to. So it was I have already said that it was a small study, but we have found that 86% women just heard about this cancer, but 49% they know that it happens from an infection, but they don't really know that what infection is that. And 62% know that cervical cancer is a fatal disease, but only 27% women know that HPV and cervical cancer are related. Okay, and this is another study I'd like to show you. It was not it was a mixed study among some people in the rural and urban area in North Bengal. It was done in 2017, and we would like to show you their belief and attitude to this cancer and other factors. So here I am showing you the table we have they have found from the study. Among these, they have done the study on like little bit more than 200 people in this urban and rural areas, and we can see that most of the people, like nearly 87% people, have heard of this cancer, but they do not really know about the awareness. They do not really know about the cause of this cancer. We can see that 96% people do not know about the cause. And nearly almost same, 93% people do not really know about the signs and symptoms, which is very concerning, because at that point maybe they are having the signs, but they do not go for the checkup. And at the same time, they don't even know about the prevention policies. Though they are more willing to go for the Pap test, but they are not very much aware of the vaccines too. And here I would like to show you another two factors, that is the age of first sexual intercourse, which is also a risk factor for this cancer, that is really low. 14 to 18 years is the like highest population that they're getting married, or by this age, as I have already showed here, that is the age of getting married is 15 to 18, most of them. So the age of first sexual intercourse is really low. And another one is I'd like to show that there are lots of women who have the habit of chewing this betel leaves or the tobacco leaves, which is also a risk factor for HPV infection in their oral areas. So from this study, we have seen that this was also a study among the similar age group between the married and unmarried people. I have already talked about these percentages, and but here we have also seen that which I have already mentioned before, that educated urban living people are more aware about these causes and signs. And the next study is a little bit interesting because it is focusing more on the parental attitude and the beliefs toward this infection and the cancer. And what I have found that here you can see a table, a chart, a graph, which is saying that most of the parents, they have heard about this infection, and they have also heard about this cancer, and they believe that this is a serious disease, but they don't really believe that their daughters can be exposed to this virus, or they can get cancer at point of their time. And there is another interesting thing I have found, that in this last bar, you can see that there are a certain number of parents who believe that this vaccination can make their girls sexually active at an earlier age. So they are scared that if the girls know that, okay, they can be protected from various STDs, that will make them go for the sexual activities at earlier age, if they know that, okay, this is a good protection. So they don't really want to go for this vaccination at earlier age for this belief. So so this is the study result we got from this study. They have done this study on like nearly 1,500 people in urban and rural areas, and like 73% parents do not really know that what is HPV, and 59% are aware that their daughters can get infected by this virus, and 64% do not really believe that they can get this cancer at later time, or 67% people think that, okay, this vaccine is not effective. And the last one I have already showed you in that graph. So here I would like to talk a little bit more about the HPV vaccination scenario in India. It has not been long that India got a license to start this vaccination program, but it has been like 13 years, but it is not very much prevalent thing in this country. So in 2008 and 2010, the research has been restricted for some political and other issues, but the vaccination has been available for prescription. In 2016, Delhi has started the vaccination. In 2017, Punjab government has started. And in 2016, they have started the VIA method for a screening program, but still this is not a very available thing everywhere. And in 2019, the 2 doses vaccine has been introduced, but after all this initiative, the vaccine is not yet much prevalent thing. So what all these studies and all this information we have found so far, we can see that the barriers to the vaccination and the screening programs are, most of the people do not really know what it is. They don't even know that what this infection can do, how far the cervical cancer can go, or it is preventable. They don't even know that information. So they don't know that how the preventable measures can work for them. And as we know that we are talking about West Bengal, my background is from East Bengal, so I know very well that how much stigmatized the sexual talk and yes, can you hear me? Yes. So how stigmatized the sexual talk, anything related to the genital area, the STDs, everything. So they don't really want to talk about it. I am not talking about the educated people. They are more inclined to it, but who are not having at least primary education, they are more like they don't really want to talk about it. And there are many wrong concepts about vaccination that I have already mentioned, that some parents think that that will make their daughters like early active, and there are other way too, that people might think that HPV vaccination can damage their reproductive system, and that will hamper their family life. And there is certainly a fear of cost because the vaccination in India is like 2,500 to 3,500 rupee per vaccine. So this is really a high price for the people from lower income. And the lack of female autonomy to decide about their own health, this is also a big barrier, because most of them have to, like a lot of them have to depend on their partners, maybe the male character at home, or maybe the father figure or husband, to decide about the screening or the vaccination program. And as they don't really know about the bad side of this cancer, there are barriers that they cannot really go for the screening programs or for the checkup too. Yes. So the gaps we found in the study, which we have already mentioned, that there are like cumulative data on India for this cancer, but still those data we do not find the year-to-year prevalence rates or any hospital registry, that not that much of available, the severity of the diseases and the prevention program which is going on in West Bengal. And I did not find much of the prevention program or the awareness campaign which might be going in the state. So no significant study has been done on the current HPV vaccination or the screening program in this region. And more data need to be collected on the barriers, more talking to the target group, or what is preventing from implementing the earlier screening or the vaccination program in these areas. And no adequate awareness, I have already mentioned it. And there is absolutely no data is available from the current patients who are already going through maybe the chemotherapy or the treatment. So there is no epidemiological data among them. So it does not give us any full picture about the epidemiological scenario of this cancer in this West Bengal region. So what we can see and at the end of this presentation, that is cervical cancer is preventable. So we can really stop having this cancer by more awareness, more data, more study. So the recommendations are there should be more state-based studies about the incidence, prevalence, barriers, and there should be increased availability of screening and vaccination programs at a lower cost, so that everyone from like different socioeconomic status, they can avail it, and create massive awareness program among the target groups, especially the parents and the adolescents are very important to know about this cancer, because the girls from 11 to upwards, they can get infected by this vaccine. I'm sorry, by this virus. And sex education is very much important from the school level. I know that is not very much easy to implement, and the community-based education is really necessary among everyone, the parents, the husbands, partners, even the males, because most of the studies are done among the women. But I find that the males are also equally responsible for knowing about all this cancer and this virus among their partners or their daughters, sisters, everyone. So that is all. Is there any question? And I just want to say at the end that this is still an ongoing research, and like more things need to be done. And anyone is interested to collaborate or make this study like take up to another level, please feel free to contact or work together. Thank you. Any question?
Thank you, Dr. Refah Khan, for your valuable presentation.
Thank you, Nawaz. Thank you, everyone.
Any questions? Are there any questions for Dr. Refah Khan? Our next speaker is Shukurellahi Mustafa from University of Ibadan, Nigeria. And I request Shukurellahi to start her presentation. Yes, please start your presentation.
Yes.
Can you please start the video and share the presentation? Yes.
Hello.
Hello.
Yes, I'm here now. Thank you so much, everyone, for your presentation so far. Thank you so much, everyone, for so far. It's been a really educative section. So basically, I'm sharing my screen now.
So I'll start with giving an overview of Everton in the community. I'll then move on to our health and wellbeing programme, hand over to Professor Andy Smith, who can talk through some specific examples of projects, who will in turn hand over to Dr. Chris Pritchard, who will talk you through his role. And it's quite a unique role that he'll talk you through. And then we'll hand back to myself to talk through our future ambition. Okay, so in terms of Everton in the community, we were established in 1988 as the official charity of Everton Football Club. So over more than 30 years, we've been delivering a range of social programmes that help tackle a number of different social challenges local to Everton in the community in a northwest area of England. Over the 30 plus years, we've won a number of awards for the work that we've been delivering, and we are now recognised as the go-to club, not just locally and nationally, but also globally. And this is something we're very proud of. And as you can see here, we've had Prince William visit us, and he's chatting here to the Everton first team goalkeeper, Jordan Pickford, who had quite a successful Euro 2000 championship. He saved a couple of penalties in the final. In terms of Everton in the community, the charity, here's a quick overview of some statistics. So we currently have 130 staff members who deliver in total 40 plus projects. And we deliver these across 140 different sites, 147 different sites. And this helps to improve accessibility onto the programme, make sure that we are fully inclusive. And we've also almost reached 150,000 people in one of our years. So this shows the impact that we have and the reach that we have. In terms of the impact, we can see here from a recent social value analysis that for every £1 invested by our various donors and sponsors and funders, this can help to generate £14.74 in societal value. So this looks at the difference made when a participant comes on board, stays with us and moves into employment, for example, improved skills, improved education, reduced crime, and improvements in various aspects of health and wellbeing. In terms of our health and wellbeing programme, which is the programme which is most aligned to today's presentation, this has always had a strong focus on tackling health inequalities and support of proportionate universalism. We deliver this across the entire life course, which I'll come on to in a moment. And we cover these three main areas: long-term health conditions, or otherwise known as non-communicable diseases, mental health conditions, and also age-related conditions. In terms of the life course provision, we take this approach because we know that there are a number of transition points across this life course where the risk of developing poor physical health or poor mental health is at a peak. So we will be able to identify these various transitional points and support the population group as they enter into that transition. Our projects range from conception via antenatal support right the way up to our oldest current participant, who is 104 years of age. So it's a very extensive continuum. And in terms of how the process works, essentially we try to identify people at risk of experiencing poor mental health or poor physical health. They will enter into our triage support system. This is delivered by various Everton in the community practitioners, and they're supported by a layer of professional support. So this includes our Everton in the community GP, Chris, who you'll hear from shortly. And essentially this triage support system is focused on identifying the needs and the interests of each individual that comes into our services. Following that, a referral can be made into one of our 40 plus projects, which fall into these three main areas here for children, adults, and older adults. And they can stay on this project for as long as they feel that there is benefit. A number of people have stayed on for more than 1 year and even beyond 10 years. A lot of people who come on as participants have then become volunteers, and we also have a number of people who are now paid staff who previously were participants. And these provide really good, strong role models for new people coming through the programme. And ultimately, the outcome at the end is to improve a range of various health outcomes and also to improve quality of life. At this stage, I'll hand over to my colleague from Edgehill University, Professor Andy Smith. Andy, over to you.
Thanks, Mike, and welcome to everyone who's listening to the presentation today. Thank you for joining us. As Mike mentioned, one of the key groups that Everton's work begins to focus on is a joint project between ourselves, Everton the community, and an organisation called Tate Liverpool, which is associated with the wider Tate partnership that colleagues may be familiar with. This programme has been running in relation to children and young people and called Tackling the Blues since 2015. And it was launched primarily given the scale of mental health need among children and young people of school age, in other words, those under the age of 16 in the UK, particularly in deprived communities such as those in the Northwest where Everton are based. Since the project launch, over 1,000 children and young people have been engaged in that programme, and currently we're now engaging nearly 300 young people every single week across a range of delivery sites and schools, which I'll come on to in relation to the next slide. The programme is delivered across a range of junior and secondary high schools, as well as other community organisations, and it's delivered by mental health trained staff who are based both at Liverpool and in other areas. The schools which we're delivering are kind of reflected in the slides that are on the screen here. They're in the 10% most deprived communities in England. And one of the key things that we try to do on this programme is to improve mental health literacy through a range of physical activity sessions weekly, which is delivered by our trained mental health mentors and delivery staff, alongside other kind of more personalised support, which is often delivered through educational workshops. And each of those workshops and activity sessions are all related to a particular theme that impacts mental health. So we address a whole range of conditions, from things like depression, anxiety, through to eating disorders and eating challenges, experiences of self-harm, as well as suicidal ideation and thoughts. That is particularly important because the programme, which focuses not only on mental health literacy, also has an early intervention component, which is associated with reductions in known conditions among children and young people, which have both economic and non-economic benefits. And on the next slide, which Mike will share with you now, we've begun to kind of identify some of the core learning that we have begun to obtain over the course of the last few months, particularly during the various national lockdowns that we've had in the UK. I know colleagues, of course, elsewhere have experienced too. And in response to that, given the few children and young people who've been able to attend school, we have developed additional online bite-sized sessions, which are underpinned by the principles of the 5 Ways to Wellbeing model. And these types of sessions, which were co-developed and co-delivered with the young people themselves, really address several key themes which are known to have significant impacts on mental health, whether that's in the form of mental illness or in other physical health conditions as well. So the focus that primarily have been the key triggers that have affected children and young people throughout the COVID pandemic, and that includes mood, reductions in loneliness and isolation, dealing with uncertainty and how to deal with uncertainty, such as the uncertainty which has characterised the present pandemic, but also the two notable conditions which have increased quite substantially among all population groups, including among children and young people, and that's anxiety and depression, with some of the latest data in the UK indicating that around 1 in 6 children and young people overall, if we leave aside deprivation and other indicators, have a probable mental disorder in the last year. That proportion increases quite substantially for those who are living in significantly socio-economically deprived communities, such as those where we work. On the next slide, what we begin to summarise are some of the key issues and key impacts that have been established as a result of the programme since we've been delivering this over the course of the last 5 years. The mentor model that we've adopted with the schools, and many of the schools have remained with us over the course of 5 years, have demonstrated a number of significant benefits for the children and young people themselves, but also for the wider school populations and the wider school staff. If we focus on children and young people, the programme has been associated with reported declines in symptomology related to anxiety and depression, as well as also experiences of self-harm, perceptions of loneliness. And we've seen elevations and sustained increases in self-esteem, trust, increased confidentiality and confidence in the children and young people, but also increased positive social relationships, which is really important for children and young people when they're particularly at school and when they're in some of the communities where they're located. For the schools and the schools more widely, the programme has helped schools to develop what are now known as whole school or whole institution approaches to health and well-being, with mental health being a central component. And this has enabled the school and staff, particularly senior teachers, to embed mental health into all aspects of the curriculum and into all of the decisions. And that may include curriculum design, but also staff CPD in relation to children's transitions between schools and other community organisations, which may include mental health specialist support services, but also in relation to the presence of, for example, pupil voice in shaping schooling and so on. So the programme is focused very much on improving the mental health and well-being and other known benefits among children and young people, but also is explicitly designed to benefit the wider activities of individual schools. And where that is typically delivered, it's because the programme is deemed by the young people themselves to be particularly engaging, it's fun, it's non-authoritarian. The people who deliver the programmes are deliberately presented in different ways to conventional teachers or school leaders, and are essentially there to support children and young people to work through the various mental health challenges that they experience throughout the course of their schooling. That's significant because in the UK, as elsewhere, 50% of all known mental health symptoms are first present by the age of 14, with nearly 3/4 of those emerging into late adolescence, early adulthood. So the programme is really important in terms of its early intervention. And this type of societal value that Mike referred to earlier more widely across Everton is also very positive for this particular programme. Between 2016 and 2018 and the latest version of that analysis, the Tackling the Blues programme was shown to have saved society 9.735 million as a consequence of the investments which we've made into the various schools and young people who work on this particular project. Those types of benefits to society and to individuals are also reflected in the next programme, which Mike will share on the screen now. And that relates to the military veterans programme that we operate together with Everton, and that we evaluate over the course of the next 5 years. This programme was established several years ago to support an unmet need, particularly in relation to unmet mental health need for military veterans and their families throughout the Merseyside region. And most recently, the programme was awarded additional funding for an additional 5 years with ourselves, given its well-reported impacts not only on reducing substance use behaviour, for example, or misuse, but also in improving mental health indicators among those with quite serious mental health problems. So we've seen significant reductions in depression, anxiety, loneliness. As you can see on some of the quotes in front of you on the screen here, some of the well-reported physical health benefits also include those associated with weight loss, reductions or abstinence from drugs, whether they're illegal or recreational, which has been particularly prominent among this population group. And what is also important is the degree to which programmes of this kind, which again are delivered by people who have lived experience and who themselves are former members of the military in terms of direct combat action, are also beneficial for physical health indicators by increasing levels of physical activity and addressing other contraindications. Chris will move on to the other types of programmes that we work collaboratively on as a group in his section now, and he'll be able to talk further around some of the more physical health conditions that we begin to address throughout the course of our work and how that relates to mental health more widely.
Thank you very much, Andy, and thank you for everyone who's joining us today, and also to the organisers for asking us to come and present our work today. It's an honour to present on this conference. So I'm going to talk about my role involved in Everton community. So I'm a GP, and I was joined just over 2 years ago to become what we know is potentially the first GP representing a football league club in the Premier League as part of their community foundation work. So the pictures in front of you show an article which has been taken from the British Medical Association magazine, which came to have a look at us in November 2019 as part of our work to try and find out some more information. And a quote which we use there is quite interesting, I think powerful, is that harnessing the powerful bond between Premiership football teams and their supporters to try and reach people who have little contact with the NHS. And there's a picture of myself standing outside the ground, and also the football ground itself, in which the community is closely linked, and also where I work around the community. Next slide. So here's a map of the Liverpool area, and in green is a picture of what's called the Wirral Peninsula. So I'm based at 4 days a week at a GP surgery, which is called Sunlight Group Practice, and essentially just a small trip across the River Mersey to Liverpool, which is based at this building, which is called the People's Hub, which is one of the Everton community buildings, which we use as our main base to try and help people in terms of the projects. It takes probably about 15-20 minutes for myself to get across there, so it's quite a short journey, but the social demographic population of where I work in my GP practice, and also the people that we see in the Everton community, is quite similar. So my role was funded in 2019 by Health Education England. It was given as a 12-month trial to try and see whether there'd be any sort of potential for taking this forward, and we found that over the first 12 months it's been quite successful, and that hopefully that this will carry on in terms of other communities and other football clubs in the Premier League trying to adopt more medical-based practitioners working in their community charity settings. As far as I'm aware, I was the first GP who's actually done this sort of project, and we've actually taken this on board to sort of promote and highlight that work in which we're doing. As part of my role working with Everton in the community, I'm sort of involved at looking at all the projects which they organise and they run, and offering my sort of medical input, which they may sometimes not be able to have, and I can offer that support and knowledge which I've gained in terms of, should there be anyone who's unwell and needs some advice, save them having to go to their own GP, they can come and see me quickly, and the staff can come and sort of liaise with myself and try and get some information which they may need. I'm also there's like a troubleshooter to try and offer some support as well for any sort of patients who come into any contact with any programs, and also to try and help any of the staff as well on the program with any sort of their physical or mental health needs. So it's quite different in terms of the work which I do for Everton community from what I would work in a normal GP practice, for a number of reasons. Often using a non-traditional medical model. So this involves seeing people in a community setting, which can be quite different in terms of patients feel a bit more relaxed. They don't feel like they have to go and see the GP in a normal way. We can dress differently in terms of using sort of clothing, but instead of using the normal sort of stethoscope and around the neck and putting some patients off, they can come into a more relaxed environment and see and chat to myself and get some more information in a community setting environment which they feel comfortable. It also involves not sort of taking the formal history and examination and providing medical management and diagnosis that we normally would, and giving some more sort of generic advice in terms of what we can offer patients in those groups. This involves screening of what we call hard to reach population groups. So as my role as a GP, I sometimes find it hard to try and get certain groups to engage. So this can involve those sort of men and women in certain populations and of certain age ranges who don't often present to GPs for a number of reasons. One could be sort of previous poor experiences. There could be previous sort of family related problems in which they wouldn't attend to see their own GP, and often trying to get them to get involved in terms of getting screened, it can be quite difficult from a medical management program. So when I get to see them in terms of Everton community programs, the sort of middle-aged men who are the football fans that attend, it's quite often rewarding to see them and try and get them involved in sort of the Everton and the community programs to try and help them a bit better. There's obviously the problems in terms of the financial and human resources available to local charities, which is quite different in terms of what I would experience working in the NHS setting. So often these charities rely on ongoing projects and funding, and the ongoing struggles in terms of which the NHS resources are often more available. A number of the projects which we run for Everton community often rely on being funded over a number of 2 or 3 years and then reapplying for any sort of further funding to keep them going. This can sometimes be a limitation in terms of the ongoing support, but we know that through the charity's work for the last few years, a number of the projects have significant longevity because of the success which they have, and this shown in terms of the patient advocates and the people who sort of continue working for Everton community, and people come back and find it's a trusted name. That can be quite rewarding in itself to try and help people. One of the key aspects of my work at Everton community is non-pharmacological methods of treatment. So we sort of use no sort of prescriptions. This is more based around diet and lifestyle. We try and encourage people to lose weight, try and engage in sort of the active programs that Everton the community have, trying to get sort of mental health improvement in terms of speaking to people. So we try and discourage the use of medication where possible. As part of working for the Everton community in the programs which they offer, it's important to still liaise with other healthcare professionals. As a GP, I'm fully aware that I'm just a single cog as part of a big wheel, so we need to make sure that other healthcare professionals who are involved in addressing the needs of these individuals are still taking place. So that can involve anyone from a physio to a podiatrist to a smoking cessation specialist to a drug and alcohol support worker to someone who's helping with employment or benefits, and making sure that it forms a joined up team to offer that holistic assessment for the whole patient and not providing them just with a single form of treatment within a community program. We can do this by making sure that the patients have full contact with their own GP still, and that any information is spread and passed back to them to make sure that there's ongoing continuity of care. We also address the needs of the individual. So we know that there's a lot of cultural differences, and we need to make sure that patients who have physical and mental health needs, that they're respected in terms of what their wishes are and how we can try and benefit them and help them. It's important to make sure that they sort of engage in a program in which a way that they feel comfortable. And it's that sort of quote that we like to use, which is called the parity of esteem, which is treating physical and mental health with equal sort of structure and making sure that you get balance to both sort of aspects of the treatment. We know from what Andy has told us before that his work and his vital sort of programs that he does make sure that the research and the structured evaluation of all the programs that we do gets audited, published, and we know that the work that we're doing is really useful. It gives great societal value. A lot of the patients that we see in around the Everton Football Club area have higher rates of substance misuse, so that includes more drug and alcohol, and that obviously increases the morbidity and mortality rate of those individuals who are involved. So we need to take that into consideration when dealing with patients who come to our programs and offering them support in terms of any sort of rehabilitation programs that may be successful for them. Again, we're looking at the support across the full lifespan. As Mike mentioned before, we have our eldest participant who's 104, and we've recently looked into doing a program for new dads to try and help and support them. So it's important that one individual engages, we try and get the whole family involved, and offering that support for the whole family gets people more involved to do more programs and stay with us for longer. I'm just going to give you a case study as an example of how my role works at Everton the community, just as a patient who I seen initially when I started. So this involves sort of a female adolescent. Her and her family presented to Everton the community following health difficulties and accessing her mental health services. She'd previously sort of been to her own GP, been to A&E, She found the difficulties of what we have in the NHS sometimes, which is long waiting times. This can be a lack of support for those young girls and children in terms of mental health and getting them that access that they need quickly. Her dad and the actual patient decided that they would go to Everton Community to seek some extra help, and I was able to speak to them pretty much the following day when they came to the community setting. Instead of, like, I'm normally afforded 10 minutes in my usual consultation role, I was given up to like 45 minutes to an hour to actually speak to this individual and their relatives. So it gives me a lot longer time to get those ideas, concerns and expectations which they need and they want to get out of speaking to a medical professional. This is a lot different from my normal role, and it obviously gives me a bit more of a structure into how to try and help someone. Because she came into Everton Community, she was able to get instant access to one of the Everton Community programs. There's often a number of programs which are different in terms of they can help different people at different age groups and what they want to get out of it. We also offered some support for the whole family, so we could always give the dad, the mom, and anyone else there who needed any help to get them on the Everton programs. This girl actually engaged in one of the programs which is called Girls On Side, and she actually remained on that, and it helped improve her physical and mental health. And as an outcome, we found that there was no further attendances to A&E. She was able to get on better with her life. She didn't go and see a GP anymore. And that sort of improvement helped, and it sort of reduced any sort of further attendances that were unnecessary. And the main thing throughout all this is that Everton Community is what we call like a trusted name, and it's quite what people sort of turn to when you don't get that help and support in a natural sort of way, and particularly from the NHS. So we find that this sort of helps. So one of the key projects that we're looking at coming up in the next sort of 12 months is a diabetes prevention project. So as we're all aware, diabetes is a major global health concern for all countries. Since COVID-19, there's been a bit of a problem in terms of getting access to services for those patients. And that includes getting the monitoring that they need in terms of blood tests and getting to see specialists and being able to see those other sort of specialists involved in terms of managing the conditions, such as any of the complications, such in terms of podiatry, eye screening, anything else which can come along with sort of diabetic complications. Liverpool as itself is an outlier in terms of complications for diabetic patients, and we have one of the highest rates of lower limb amputations in the country. This can be correlated sometimes with the socioeconomic deprivation in some areas in which diabetes can be sort of poorly managed by some patients, and they may have lack of access to services. So we tried to do a pilot study in which we were quite successful in November 2019 and part of World Diabetes Day. We did screening, which involved point of care testing for fans who came to the game, and 50% of the fans that we tested were either pre-diabetic or diabetic, which we found those sort of ticking time bombs of individuals walking around who have these high blood sugars and potentially increased comorbidities, who actually need that sort of medical input to try and get the blood sugars down through diet and lifestyle management and other ways and means. So this has led on to funding that we've received for the next 12 months in terms of actually commencing our diabetes prevention project. So we're going to be able to do this through a couple of ways. The initial part will involve patient recruitment, which can involve further screening events from individuals attending the football matches over the next season, which we're hopeful that COVID restrictions have now eased in the United Kingdom and that full attendance should be possible at the moment. This will increase the number of individuals that are able to come, and we can potentially get more people through who can do that point of care testing. The other avenue which we can use is that patients who are engaged in the primary care aspect of diabetes prevention, if they've failed to engage properly with the National Diabetes Prevention Programme, we're able to offer them this as a second opportunity to go to the Everton Community setting and get more of a friendly support and from the coordinator, which you can help support them for the next 12 weeks. We may also get some referrals from secondary care and other community clinics from those patients who may also need some extra help and support in terms of the diabetes. One of the things that we can do is to find out why patients didn't engage with the National Diabetes Prevention Programme. We can spend longer with them, we can offer them a community setting. This can be either done on a virtual or face-to-face basis, and try and find out what the needs of that patient are. This then goes on to a 12-week structured programme with Everton community. So the main components of this are going to be diet and lifestyle management, physical activity classes, and then offering that holistic assessment and support in terms of employment, housing, benefits, and mental health provision, of which chronic illnesses such as diabetes can often affect. The patient outcomes which we're looking to get from this diabetes programme. So primarily we're looking for weight loss and reduction in HbA1c, and hopefully this should correlate with a reduction in blood pressure for most of the patients who get involved into the programmes. Ultimately, they should have diet and lifestyle improvements. We're looking for those mental health outcomes that are going to be improved as well. Reduction in social isolation from individuals who are attending these community programs and engaging in groups and like-minded individuals. There may be some of those people who have improved health in their comorbidities. There's like to be a number of them who suffer from asthma, COPD, high blood pressure. And we ultimately aim to see a reduction in medication burden, which again goes to the cost and society value of what Everton and the community does in terms of reducing any sort of long-term costs for the NHS. Through Andy's team, we're able to use evaluation of what community programs we can do through mental health questionnaires, the quantitative physical measurements that we've already mentioned, and then reassessment of patients in 6 to 12 month periods. The longevity of these programs relies on developing patient advocates and increased recruitment for community programs, and we expect hopefully that these programs will continue for the next few years, even though it's an initial 12-month program. Hopefully these sort of community programs may sort of form into that part of the diabetic prevention program nationally, and that is ultimately our aim, is trying to expand this further and recruit and sustain this program as long as we can. So just looking ahead, we're looking at some new projects which we'll be doing over the course of the next 12 months at Everton Community, and which I'll be involved. We are now looking at supporting new dads in terms of the mental health. So we know that around the Merseyside and Cheshire area, there is a lack of provision in terms of offering mental health support for those new dads, and 1 in 10 of new dads suffer from mental health problems, which is likely to be an underestimate in terms of the support which they may need, and also ongoing in terms of whether the mum or any other partner is also suffering from mental health illness. So that's quite sort of interesting in terms of the work that we'll be doing. Another project which we'll be doing is looking at screening patients and fans for atrial fibrillation. So this is an irregular pulse, which is the main sort of leading cause of strokes. We often find that a lot of patients who have this condition don't realise they've got it, and sometimes it can be too late. By the time they've had a stroke, the catastrophic events are non-reversible, and it can lead to sort of long-lasting damage for the patient. It also has significant economic burden for the rest of the community and also the NHS. So again, we'll be doing point of care screening testing for looking at patients' pulses and trying to identify those patients who have an irregular pulse and getting them managed and treated quickly and efficiently, and also engaging on any Everton community programs. We're also looking at ADHD, attention deficit hyperactivity disorder. So recently within the United Kingdom, there's been a problem in terms of patients getting access to see specialists in terms of diagnosis and management of this condition. We should be able to try and get improved sort of holistic support for any children who have not been able to get access to these services through COVID, and we'll be able to get some extra screening tools involved. Also for cardiac screening, we have had previous sort of screening programs which have looked at cardiomyopathies and also found some patients who, again, have been walking around as ticking time bombs. And we are hoping to do further screening events, looking at those patients who can come to the community programs and get screened, and if necessary, get referred onto a local hospital should any abnormalities be found. I have recently had funded a GP training program for a GP trainee to work with myself as part of the Everton community programs. Again, this will be the first one in the country of its kind, and we're very excited to try and have this new person on board to help with us with our programs. So as part of the GP training program, we have the initial 2 years foundation working within a hospital setting, and then the next 3 years is a mixture of working in GPs and further ongoing hospital settings for a GP trainee. Unfortunately, there's very little sort of community work which they engage with, and this will be a great opportunity for someone to try and learn how a community charity works in terms of the financial constraints and also the non-medical model, which we mentioned before. This will be sort of evaluated over the next 12 months to see whether this can continue, but obviously we have great links with Andy, and we can obviously do further research which allows us to determine any sort of improvements which may be needed towards the projects. So I'll hand back over to Mike, who will conclude the rest of the presentation.
Thanks very much, Chris, and thank you for all your work that you've been doing with ourselves over the last 2 years. You've made an excellent impact with us. Just to finish off, I'll talk through 2 final areas. One is the People's Place, and then the second is the Goodison Legacy. In terms of the People's Place, this is a new mental health hub with a strong focus on suicide prevention. We know that suicide is a significant global public health challenge. There are over 800,000 people that die by suicide every year across the world. Across the UK, there's over 6,000 people that die by suicide. It's something which is a massive challenge, and locally we're looking to help support the whole suicide prevention agenda by developing the People's Place. The People's Place will be the first of its kind mental health hub aligned to a Premier League football club community foundation. The main focus is around promoting good mental health and also suicide prevention. It'll be a facility which will be fully inclusive, provide an overarching service to anyone regardless of age, gender, location, football allegiance. And there'll be a broad range of activities delivered from within the building. These are all evidence-based to improve mental health, and they fall into these 4 main categories here: sports and physical activity, education and development, signposting and awareness, and also community engagement. In terms of inside the venue, we want to make this look as welcoming and impressive to the population groups that we're looking to target. We want to ensure that people feel a great sense of self-worth when they come to the venue. They feel comfortable and they feel able to spend long time periods here so they can really benefit from the various activities that will be delivered. In terms of the outside, this is what it would look like from the street view. Previously, this was derelict land, a hotspot for antisocial behaviour. So not only is it improving the whole look of the area aesthetically, but it's also providing a very important resource to the local community. This leads me on to a bigger piece of work, which is with regards to Goodison Park, which is the current Everton Football Club football stadium. So the plan in 2025 is for Everton Football Club to relocate to a new stadium, which will be on Bramley-Moore Dock, about 3 to 4 miles away. And the current Goodison Park Stadium will be transformed into a huge expansion for Everton in the community. It will be a significant regeneration scheme to an estimated value of 100 million. And it will include these different aspects here. It'll include a health zone, which Dr. Chris Pritchard will be at the heart of in terms of having our own GP practice within that health zone. There'll also be support around dementia, research will be at the core of that work. And then there'll also be a lot of other aspects to it, including retail and leisure to help in terms of sustainability, a youth zone, education zone, enterprise zone, and also quality, affordable housing. All of this will be wrapped up in good quality green space as well, which we know is so important for mental health. Here are some of the different activity streams that will take place, which we touched upon. Non-abandonment is a key objective. Also having the Everton theme run across everything, but significantly and importantly having Everton in a community in a position where they're able to expand significantly and further develop on from the £14.74 value for societal benefits for every £1 invested. The whole piece of work is estimated to generate £240 million in societal value. So it is a significant project that we're undertaking now, and we're looking forward to this launch in 2025. In terms of the Everton Football Club Stadium, this will be relocated, as I say, about 3 or 4 miles away to Brownlee-Moor Dock, and this is what the new stadium will look like. Thank you very much for your time, and if you want to make contact, our email addresses are on the bottom of the screen here. But yes, thank you for the opportunity to present, and also just a big thank you to Andy Smith from Edgell University, our academic partners for over 8 years now, and also Dr. Chris Pritchard, our GP for over 2 years now. Thank you very much. If there are any questions for any of us three, please fire away. Thank you.
Thank you, gentlemen. Thank you for the wonderful presentation. Thank you so much. And I guess it is the Brownlee-Moor Dock Stadium.
Yes, that's correct. Brownlee-Moor Dock Stadium. Yes, that'll be fully operational 2025 for Everton Football Club.
Okay, 2025. And there is a controversy around it regarding the World Heritage, UNESCO's heritage being removed from Liverpool City because of this stadium, I guess.
Yeah, that's correct. It's been a difficult time in terms of a balancing act between making sure we can provide the benefits of the new stadium, which are not only for the football club, but for the whole of the city region. This will be something that creates 15,000 jobs and helps with the whole community in terms of the tackling the various health and wellbeing challenges, and some of the challenges that we've discussed on this presentation now. And maintaining that title, the Everton Stadium was one piece of that UNESCO title. There's other items that were also involved with that decision being made. But yeah, it's disappointing that the title was removed. But from a personal point of view, when we look at the impact of the development, when we look at the benefit that will bring to the city region, I would say it's far more important than the UNESCO title, even though we would not want to lose that title.
What happens to Goodison Park?
So Goodison Park, if I skip back a couple of slides, the current Goodison Park will be transformed into what we can see here. This is where Everton and the community will expand significantly, and we'll have support from Andy and Edgell University in terms of the research and monitoring of all the projects and evaluation. We'll have Dr. Chris involved with the health zone, his GP practice, but all of this additional activity will take place at the current Goodison Park Stadium.
Thank you. Thank you so much. Yes, any more questions?
Hello. Yes, thank you, Michael, Professor Andy, and Dr. Christopher. That was a great presentation. My question concerns children 18 years and below that are battling with mental health issues and end up joining gangs to seek solace. And unfortunately, most of these children come from broken homes, and their parents don't really they don't observe the children and see their characters in order to get them help. So do you have any program which directly targets these children that join gangs?
I think the Tackling the Blues program that we referred to previously is the main project that we currently work with children and young people. And some of those people who attend that particular program are either experiencing currently mental illness and have received a formal diagnosis, or they're at risk of developing such a diagnosis. And the reasons why we have those who are at risk of receiving a diagnosis is primarily because of the long waiting list which exists to access CAMHS in the local region, and this is something which you find in many other areas across the UK, but it's a particular challenge in the areas where we work. And actually, one of the reasons why obviously the program was developed was to help support those young people who weren't received the type of support that you've just referred to, whether that's support from people at home and or from specialist mental health services that focus on children and young people, and really ensuring that we can kind of intervene early, and by working with young people who may otherwise have accessed or entered the specialist mental health pathways, if we can begin to address some of those challenges in schools or with some of the other community wraparound services, then that may actually help those young people, not only in the immediate term, but in the longer term, and may prevent their access to CAMHS. As part of that programme, we also do work quite closely, where possible, with parents and with other community groups to address some of the major social determinants of mental health, which are well known. And some of those, of course, can be controlled or influenced by the programme, and many can't. So for those where we couldn't reasonably be expected to have a significant impact, what we try to do is to link together the various community resources that we have at our disposal. Some of those are located in schools, some are around school sites and in communities, and try to use those to help refer our children and young people into appropriate services, whether that's CAMHS or others. But it very much does depend at the moment on the specialist waiting list for those children and young people. And unfortunately at the moment, particularly in the UK, what we're seeing is those, certainly in areas of deprivation, such as those where we work, there are far fewer young people entering specialist services. The waiting lists are beginning to increase quite substantially. And what that means is there's a significant potential mental health burden that is currently being experienced by children and young people that is not really being met. And that's why I think for this particular program, it's especially important that we continue to do that, particularly given the challenges that, of course, COVID has presented. And I think the online activity that we referred to earlier was another opportunity really for us to try to support those very vulnerable young people who you referred to earlier while they were at home in the company of others, whether they're parents or other siblings, or in some cases carers. So what we've begun to find is that some of these resources are being used at home by some of those young people who perhaps otherwise wouldn't have engaged in this programme. We still do see something of an inverse care law at times, that those who do need it the most sometimes use it the least. And that's, I think, that's one of the central challenges, regardless of the target population or health condition that we've talked about, that we continue to encounter. And that really just kind of emphasised the need for the types of activity that we've referred to. But it is a challenge. It remains a challenge to engage some of those people who are, for various reasons, unable to support children and young people in relation to their mental health. I'm not sure, Chris, if there's anything from your perspective as a GP, given the mental health need that we're seeing for children and young people, that you might want to comment on.
Thanks, Andy. Yeah, I think as a GP, it's quite a big rise over in COVID in terms of mental health problems presented in young children and adolescents, and the lack of services which have been available to them in the last sort of 12 to 18 months. Finding that children are sort of reaching a crisis point a lot earlier, and there's lack of sort of intermediate and early services available to them. And so these sort of support programs that we can do for us in the community are quite vital in terms of offering that community setting and getting in there early into schools, into buildings where we know that young people congregate. A lot of problems that can arise in areas of social deprivation is that when children get despondent in terms of mental health, is that they make it fall more into sort of drugs and alcohol situations, and there may be sort of increased risk of them falling into the gang culture and get swept away then, and they get sort of lifelong problems, which we know that when they have mental health issues from a young age, they can sort of perpetuate and become a lot worse as they get older, and you fighting a losing battle. And particularly find working in a GP setting that those lack of resources that we have, it makes it very difficult for us to try and manage, and patients and parents come to us and ask us for help, and we just have limited sort of funding and opportunities to give them. So the more sort of programs we can try and do like this, it really does help those communities, and we can try and get those children sort of that extra input from a younger age and get them back on the right track, get them into employment, get those qualifications which are useful for them, get those stable relationships in their family and friends, get them away from drugs and alcohol. And that longevity sort of really does have an improvement in society, but it really is a hard battle. And as Andy mentioned, it's the inverse care lawyers that we're trying to find those people who need it the most but don't access the services. And I think as a GP, that's probably only going to get more difficult for ourselves in primary care and secondary care over the next sort of couple of years. So I think the more we can try and do to try and help these people, I think the better.
Okay. Any more questions? Okay. Thank you so much, gentlemen. That was really excellent presentation. Thank you so much.
Thank you.
Thank you. And I request Shakurillahi Mustafa to start her presentation.
Thank you. Thank you all for your presentations so far. It's been really educative and enlightening. First of all, I would like to apologize for the earlier glitch in technical processes. So now I will start my presentation. I'll be talking about tackling Neisseria gonorrhea, antimicrobial resistance in England, and the public health perspective. So, Neisseria gonorrhea is a gram-negative difolic bacteria, which is usually sexually transmitted, mainly sexually transmitted, although it can also be transmitted perinatal, that is from mother to child, through childbirth. And also studies have shown that it could also be transmitted via kissing, especially in gay male population. It was firstly isolated by Albert Neisser, and it usually affects the mucosal layer alongside the other reproductive organs and other parts of the body which it affects, such as the pharyngeal area in the case of pharyngeal gonorrhea, and it strictly affects humans. It has not been known to affect animals, and it could affect the male, the female, the old and young. There has been a series of antimicrobial antibiotic resistance in the case of the treatment of Neisseria gonorrhea. This is because this microorganism has over time been able to mutate, has over time been able to bypass different antibiotic drugs that has been discovered in order to treat it. And due to its frequent mutative properties, vaccines have been difficult to get for Neisseria gonorrhea, although studies are still going on, and there's still process going on making vaccines for Neisseria gonorrhea to prevent having Neisseria gonorrhea. And also the antibiotic treatment, really, over the years, there has been issues with the antibiotic that we have been using, from penicillins to fluoroquinolones, and right now we are more or less at the last bus stop where we don't even know where to go again, although there's still resistance to the present therapy, which is the cephalosporins. So it's a sexually transmitted infection, like I said earlier, and on a daily basis, we have more than 1 million people acquiring this infection. It is responsible for over a quarter of sexually transmitted infections globally, and it causes mortality, cancer, infertility in both genders. In 2013, gonorrhea was responsible for about 314 disability-adjusted years and 225,400 years lived with disability year. It's actually responsible for 1,000 deaths in 2015, and this number almost doubled in figure over the years. So as the years goes by, as decades goes by, we tend to see an increase in the number of infections, in the number of deaths, in the number of lives affected with Neisseria gonorrhea. Public Health England revealed that in 2017 they had 44,676 cases, and that was a 22% increase compared to the previous year. So we keep having the incidence rate increasing, and this is due to the fact that antimicrobials used are, and this is basically due to the fact that the whole treatment cascade is not sufficient, is not enough. This is a graphical representation showing the incidence of gonorrhea over the decade compared to that of syphilis. And as you can see, that of syphilis is really low compared to that of gonorrhea, which just keeps skyrocketing and keeps increasing over the years. Neisseria gonorrhea has over time developed resistance to therapies, necessitating adjustments in various, and have to adjust the doses of the medications given, eventually transit to other antibiotics, and now is developing resistance to the present first line of antibiotics use, which is the third generation cephalosporins, like I said earlier, and this has progressively impeded the control of this infection. So this is a graphical representation of the different antibiotics that has been used over the years since the time it was discovered. You can see that penicillins were used at some point, and then it grew resistance. At some point, then we had to increase the dose, and then it grew resistance to penicillin. Then we had to use some tetracyclines, fluoroquinolones, and as at 2007, fluoroquinolones were no longer recommended. This is because of the high rate of resistance. And now we are using the cephalosporins, and resistance have also been recorded as regards the use of cephalosporins. This is graphical representation of global resistance to, as it was saying, this is at 2014 to broad spectrum cephalosporins and to fluoroquinolones. As you can see, this from this graphical representation, this microbiome has developed resistance to most of the drugs we are using. Here, the resistance is even very high for fluoroquinolones. That's why they are not even used at all. There were at least 34 confirmed cases of drug resistance to Neisseria gonorrhea reported in England. And between November and April 2016, and now we had two new cases in January 2019. This 34 is actually a very high figure, considering the fact that this is to the present treatment guideline, that's cephalosporins. And surveillance has been put in place to monitor this trend. There's currently no alternative. Like I said, we are more or less like at our last bus stop as regards the antibacterial agents used in treatment of this condition. Although studies are still going on, trying to figure out what other ways. Is it the vaccines? Is it developing other antimicrobial agents, just so we can tackle this Neisseria gonorrhea. And Neisseria gonorrhea has shown to be very mutative, like I said earlier, making vaccines very hard to develop. So we keep wondering, why do we have gonorrhea this difficult to treat? Why has it been so hard? So we realize that this gonorrhea is actually something that is associated with social determinants of health, such as poverty, unemployment, social and sexual properties, education, sexual groups, inadequate healthcare, and medications abuse. So poverty has actually driven a lot to, is actually a driver to certain jobs such as sex works, and people that are involved in such activities probably don't even protect themselves very well, and then they spread it from one person to another. And areas with low economic income, they have to go out of their ways to probably just do things without thinking of the consequences so much, just to get something to feed themselves. And they've had higher numbers of partner change, and they are all in clustered areas, thereby promoting the spread of this disease. This is further worsened by some certain sexual practices, such as oral sex. Like I said earlier, it's sexually transmitted. It could be their vaginal sex, anal sex, oral sex. All this predisposes to gonorrhea, and with the oral sex, it predisposes more to pharyngeal gonorrhea. Aside oral sex, there are other properties, there are other social practices, such as drinking urine as medicine, which also causes pharyngeal gonorrhea. And having another type of gonorrhea aside the usual type also has linked to high drug resistance strains. Higher incidence of gonorrhea infection have been found in youths, men who have sex with men, and in Black population. Inadequate healthcare has also been shown to facilitate onward transmission of this disease. Insufficient service capacity leading to delayed treatment. Poor contact tracing. So, I mean, when people come into the hospital, they get treated, we don't go extra mile to ask, okay, who is your sexual partner? Can your sexual partner come and get treated as well? And then who are the other people you've been in contact with sexually? This contact tracing is something that we haven't really done well, and that has definitely caused a risk factor for the spread of this disease. And like I said, the gonorrhea infection is a sign of an individual belonging to a higher risk, of making it more important to. So people that come in to the hospital with gonorrhea, they definitely belong to one of these risk factors, these high risk groups that I have already mentioned, the poor, the people that are less educated. And some people also use antibiotics in animals. They use it in food, and all these fake medications have also not been helpful, and have also been shown to promote antimicrobial resistance of this microorganism. This is just a representation of London, and the central part is showing a darker clustered area. This is actually showing that there is more incidence in those darker places, and it's all clustered together, like I said. So it's something that is being shared. It's being shared all around and in that same cluster region, and gradually it keeps spreading bit by bit, but there's still that cluster somewhere. This is a picture of someone drinking urine, as some people believe that urine has some sort of medical use, which of course is wrong. So what do we have? How do we tackle this problem? I mean, we keep having antimicrobial resistance, the disease keeps spreading. So how do we actually tackle it? We have interventions, we have medical interventions, we have behavioral interventions, and structural interventions. These strategies are to combat all this was structured by the WHO, the WHO Global Action Plan, European Center for Disease Control Response Plan, and the gonococcal resistance to antimicrobial surveillance program action plan for England and Wales. So what's their plan? Like, what do they want to do? They actually aim to improve early detection of the disease, to offer appropriate, effective treatments, educate patients effectively. This high-risk group of people, especially high-risk group of people, to ensure that there is good compliance of the health providers. Surveillance is being done very well, capacity building, policies and advocacies, guideline formation, etc. Everything I'm going to explain one by one. And then, so these interventions, the structural interventions to address inequalities. I mean, if the government is able to actually breach that, let there be a base standard of living, let people not have to do sex work to feed themselves. And if that is being covered, if people that have to do that are not doing that anymore, I think there'll be less transmission of this infection. And then provision of better healthcare system, research funding, and policies safeguarding antibiotics use. People shouldn't just use antibiotics, and then when people use antibiotics, they should complete their dosage regimen, use it appropriately, and there should also be laws promoting the reduction in counterfeit medications, fake drugs, inadequate drugs, people should use their medications well, and also educate people. Let people be aware. Let them know that okay, these are ways where they could actually prevent themselves from getting gonococcal gonorrhea, like basically sensitizing them, let them be aware, using protection when having sexual intercourse. Let them know that okay, this thing, if peradventure it happens, when you get to the hospital, let the healthcare providers know. Let them know your sexual partner, your history, so that, and then your sexual partners, they shouldn't feel ashamed to come into the hospital to actually get themselves treated. It's very important that these people are being traced and everyone gets the medication they require. Also, behavioral intervention. Like I said, people should be educated about safe sex. They should be educated about how to prevent themselves from getting this infection. They should counsel anytime they come to the hospital. They shouldn't be ashamed of anything. There'll be counselors. They'll talk to them. There is no awareness program to reduce stigmas and ensure safe practices. These are behavioral intervention things to do so that people can be more open about their health. People can feel freer about their health. People, and when they know about these conditions, when they know about these infections, they would actually be willing to complete their dosage regimen. I mean, a lot of people decide antibiotic treatment, they don't finish it. Eventually, they are not able to get the required therapeutic outcome. They're not able to get the required therapeutic outcome, so eventually they don't even get better on the long run. So, but if they know that okay, take your antibiotic regimen, take it fully, take the full dose, it's easier, and they would of course adhere to every single thing they are being told or they are being counseled upon. And then the biomedical interventions. As regards the mother and child, like I said earlier, aside being sexually transmitted, it's also transmitted through the mother and child, especially during childbirth. So, and this can be prevented the mother who is already pregnant and maybe she gets infected with gonorrhea is actually on her medications and she's taking them appropriately. So these medications will definitely help to prevent the transmission of gonorrhea from the mother to the child. Early treatment, people, as long as they start having symptoms of gonorrhea, they should report to the hospital immediately so that we are able to start their treatment early, and also testing, counseling, follow-up. Even after they have left the hospital, there should be a follow-up. There should be a comeback. There should be something to make sure that, oh, this person did finish their regimen. This person actually felt good after. This person, we're able to achieve therapeutic outcome in this person. If we're actually able to do this, all these interventions, if we're able to do them to every single person who comes into the hospital, I believe that despite the fact that we don't have much antibacterial agents to use to treatment of Neisseria gonorrhea, that doesn't mean that we will not be able to curb this transmission, this fast transmission that is occurring. And over time, if we're able to curb this fast transmission, we'll eventually be able to develop a vaccine. Because if we're able to do all this, we should have less mutated Neisseria gonorrhea bacterium, and at least we'll be able to finally develop a vaccine that can be used in the prevention of Neisseria gonorrhea. So basically, this antimicrobial resistance is on the high, it's actually on the rising side. It's a great concern to the public health, and the reduction in inadequacy should be prioritized in reversing this side. So, like I said, if we are able to do the interventions, that would also help to minimize and hopefully reverse this antimicrobial resistance. And currently, no country has been able to achieve a reversal or elimination of antimicrobial resistance. So we're hoping that with time, we'll be able to get that done. Furthermore, the development of more effective medications and vaccines are important in halting the current trend. So we need effective medications to stop, and then vaccines so that we can stop this microbial agent from being transmitted and the incidence from increasing. I mean, we've been dealing with this microbiome for a very long time. It's high time that we tackle it and we fight it with all means that we have. These are necessary considerations to tackle antimicrobial resistance. So all this that we have put in place, hopefully, to reduce and help with the existing antimicrobial agents that we have that is currently still working, even though resistance has been developed for it as well. We hope that all these extra measures would definitely help in tackling this antimicrobial resistance. So thank you very much. Any questions?